So, good evening all. For the next 20 or 25 minutes maximum, we are going to discuss the topic of scapular region and shoulder region. Scapular region and shoulder region. Fine. So, whatever possible MCQ questions that may be asked from these two regions, we will be discussing, right? So, initially, some 8 to 10 slides, we will be seeing the images with labeled. Okay, all the points will be labeled. Then I am having some blank images. When I'm asking questions, try to answer those questions. Okay, so if you listen the class carefully for the first 10 minutes, then when I'm asking the questions from the blank images, you will be able to answer. Okay, because usually all the questions almost asked from these regions will be image based. So please. So in the scapular region, what we are seeing here in this diagram is the anterior view of the scapula. Okay, you are seeing the scapula bone from front, anterior view of the scapula. Okay, so this is the scapula bone. We are seeing from front, anterior view. Okay, so this is clavicle bone, isn't it? So just below the clavicle, do you see one particular part of the scapula bone? What is the name of the particular part of the scapula bone which is located just below the clavicle, called as? Specifically just below the lateral 1/3 of the clavicle, just below the lateral 1/3 of the clavicle bone. Yes, it is called as coracoid process of scapula. Fine, coracoid process of scapula, isn't it? So let's talk about the 3 or 4 important points regarding the coracoid process of scapula. Okay, this coracoid process of scapula gives attachment to 3 muscles. Okay, so what are the 3 muscles attached to the coracoid process of scapula? One is coracobrachialis, then short head of biceps brachii, then pectoralis minor. Okay, so these are the 3 muscles attached to the coracoid process of the scapula. Fine, coracobrachialis, short head of biceps brachii, and pectoralis minor. Fine. And another important point about the coracoid process of scapula is what type of epiphysis is coracoid process? The answer is atavistic epiphysis. Okay, coracoid process is a classical example for atavistic epiphysis. Fine. And one more important thing regarding the coracoid process, okay, is it is the bony landmark that is palpable, okay, just below the clavicle, isn't it? So it is the bony landmark palpable in the infraclavicular fossa. You can easily understand the meaning of infraclavicular fossa, isn't it? Fossa means depression. Fossa means depression. So just below the lateral 1/3 of clavicle, we have a depression called as infraclavicular fossa. The bony landmark palpable in the infraclavicular fossa is coracoid process of scapula. So try to understand all the things by having an idea, imagining this bone, scapula bone. Fine. Okay. Now, so these are the 3 important points about the coracoid process of scapula. Fine. So let's move to the another important landmark of the scapula called as acromion process of the scapula. Okay, acromion process of the scapula. Okay, so what are the important points about the acromion process of scapula? As you see here, it is the topmost or uppermost bony landmark of the shoulder region. It is the topmost or uppermost bony landmark of the shoulder region. Okay, this question has been asked. Okay, and remember, there is one ligament extending between, okay, ligament extending between coracoid process and acromion process. So what will be the name of the ligament? Coracoacromial ligament. Okay, see the lower part of the slide, coracoacromial ligament extending from coracoid process and acromion process. Okay, so what is the importance of the coracoacromial ligament? It is located just above the shoulder joint, right? You can see the coracoacromial ligament is located just above the shoulder joint, isn't it? So obviously this coracoacromial ligament supports the shoulder joint from above. That means it prevents the superior dislocation of the shoulder joint. Since it is located above, it prevents the superior dislocation of the shoulder joint. And another important point about the coracoacromial ligament is it forms the secondary socket for the shoulder joint, okay, or you can say secondary socket for the head of the humerus bone, okay, head of humerus, fine. So remember the two important things about the coracoacromial ligament, fine. And other things here we have to remember is, see, right now, do you see the glenoid cavity of the scapula? One shallow depression called as glenoid cavity of scapula. This one, this black color, glenoid cavity of scapula, okay, which is a shallow depression. So just above the glenoid cavity of the scapula, you will be having one small elevation called a supraglenoid tubercle. Supraglenoid tubercle, okay. And the importance of the supraglenoid tubercle is it gives origin to the long head of biceps brachii. Supraglenoid tubercle gives origin to the long head of biceps brachii. And the peculiarity of the long head of biceps brachii origin is it is intracapsular origin. It arises within inside the fibrous capsule of the shoulder joint. Intracapsular origin. Fine. This has been asked again, okay. And you can see after arising from the supraglenoid tubercle, the long head of biceps brachii tendon passes through intertubercular sulcus. Okay, between the greater tubercle and the lesser tubercle of humerus bone, we have intertubercular sulcus, otherwise called as bicipital groove. The question is, what is the structure passing through the bicipital groove or intertubercular sulcus of humerus? The answer is tendon of long head of biceps brachii. Tendon of long head of biceps brachii. Fine. Okay. And not only tendon of long head of biceps brachii, one more structure passing through the bicipital groove or intertubercular sulcus is ascending branch. Okay. Ascending branch of anterior circumflex humeral artery. Ascending branch of anterior circumflex humeral artery. Fine. These are the two structures passing through the intertubercular sulcus, also called as bicipital groove. Is it okay? Fine. Now coming to the infraglenoid tubercle. See, just below the glenoid cavity, do you see one small elevation called as infraglenoid tubercle? And this infraglenoid tubercle gives origin to long head of triceps. Long head of triceps. Okay. So take care of all the things we have discussed in this slide. Okay. Let's move to the next slide. Okay, fine. This is the posterior view of the scapula. You are seeing the scapula bone from behind. Okay. Posterior view or dorsal view of the scapula. Fine. Okay. So do you see one projection called as spine of scapula? Starting from here to here, this whole area is called as spine of scapula. Okay. So, and listen, this is the superior angle of the scapula and this is the inferior angle of the scapula. Okay. Actually, we are seeing the scapula of right side from behind. So this is medial side, this is lateral side, this is superior and this is inferior aspect of the right scapula. Is it okay? So extending from superior angle to the inferior angle, we have the medial border. Okay, we have the medial border of the scapula. Okay, so the question is, what are the three muscles, okay, attached to the medial border of the scapula? From above downwards, the three muscles getting attached to the medial border of the scapula are, okay, so you have to remember in order all the three muscles which are marked as 1, 2, 3. Levator scapulae, rhomboid minor, rhomboid major. Okay. Levator scapulae is getting inserted here. Rhomboid minor is getting inserted here. Rhomboid major is getting inserted here. Okay. All these three muscles are getting inserted into the medial border of the scapula. Fine. And one more thing is, all these three muscles are supplied by dorsal scapular nerve. Okay, all these three muscles which are getting inserted into the medial border of scapula, they are supplied by one nerve called as dorsal scapular nerve. This question has been asked in NEET PG 2020. Okay, last year. Okay, so take care. They have marked the levator scapulae muscle in the image, and what is the nerve supply for the marked muscle? That was the question. The answer is dorsal scapular nerve. Okay, all these three muscles are supplied by dorsal scapular nerve. Fine. Okay. Now coming to the lateral border of the scapula. Right now I am tracing the lateral border of the scapula. Right. So the lateral border of scapula gives attachment or origin to two muscles. What are the two muscles marked as number 1, number 2? Yes, teres minor above. Okay, from the upper part we have the origin of teres minor. From the lower part of the lateral border we have the origin of teres major. Okay. Fine. So from this diagram, I want you to know the three muscles attached to medial border of scapula in order, and two muscles attached to the lateral border of the scapula. Fine. Okay, let's move to the next slide. Okay. So from this diagram, you can understand whatever we have discussed now, isn't it? So this is the medial border of the scapula. You know the three muscles from above downwards getting attached or inserted into the medial border of scapula, isn't it? 1, 2, 3. And this is the lateral border of the scapula. You know the two muscles arising from the lateral border of scapula. Teres minor above, teres major below. Fine. Then other things we have to remember from this diagram. This is the trapezius muscle. Okay. This is the outline of trapezius muscle. Fine. So regarding the trapezius muscle, the 3 or 4 important points are: it is triangular in shape. Okay. The trapezius muscle is triangular in shape. Remember, this has been asked in NEET 2019. Okay. What is the shape of trapezius muscle? The answer is triangular in shape. If you see the outline, you can understand. Okay. If you consider the trapezius muscles of both sides, it is trapezoid in outline. But if you consider trapezius muscle of one side, it is triangular in shape. Okay. Triangular in shape. Okay. And what is the nerve supply for the trapezius? Exactly. Spinal accessory nerve. Okay. Sternocleidomastoid muscle and the trapezius muscle both are supplied by spinal accessory nerve. Fine. So if there is injury to the spinal accessory nerve, sternocleidomastoid and trapezius muscles both will get paralyzed. Fine. So what is the normal action of the trapezius muscle? Trapezius muscle causes elevation of the shoulder, otherwise called as shrugging of shoulder, elevation of shoulder or shrugging of shoulder. So if there is injury to the spinal accessory nerve, trapezius will undergo paralysis. So there will be inability to shrug the shoulder. Patient cannot elevate or cannot shrug the shoulder. Okay, that is called as drooping of shoulder. Drooping of shoulder. So if the question is asked like drooping of shoulder is due to injury to which nerve, which muscle, you should be able to answer. Right? Now, see the another muscle which is labeled in this image. This is the deltoid muscle. Okay, deltoid muscle. You know, deltoid is the muscle forming the shoulder region. The shoulder region is formed by the deltoid muscle. What is the nerve supply for the deltoid muscle? Axillary nerve. Deltoid is supplied by axillary nerve. Deltoid and teres minor both are supplied by axillary nerve. Fine. And can you see the latissimus dorsi muscle in this diagram? Okay, this black color outline is representing the latissimus dorsi muscle. Fine. Okay. Now, please listen. This is the scapula bone. Okay. One side they have exposed the scapula, another side they have shown the muscles which are covering the scapula. Okay. So do you see one triangular shaped area called as triangle of auscultation? Okay. So the question may be asked like, what are the structures forming the boundaries of the triangle of auscultation? Okay. So from the name itself, you can easily understand the three structures forming the boundaries of triangle of auscultation. TR representing the trapezius muscle. Okay, SC in auscultation, SC representing the scapula bone, exactly saying medial border of scapula. Then LTAT, okay, LAT, latissimus dorsi muscle. Okay, so these are the three muscles. Sorry, these are the three structures forming the boundaries of triangle of auscultation. Okay, fine. So any one may be exception, like serratus anterior, That will be the usual exception given in the MCQ. All the following structures form the triangle of auscultation boundaries except. Fine. Okay. And remember, the so-called SIT muscles, namely supraspinatus, infraspinatus, and teres minor. All these three muscles, they get inserted into which part of the humerus? Anybody? Greater tubercle of humerus. Okay. Supraspinatus, infraspinatus, teres minor. All these three muscles, SIT muscles. Okay. They are getting inserted into the greater tubercle of humerus. Fine. Now, moving to the topic scapular spaces, otherwise called as intermuscular spaces. Okay. So you can understand this diagram. Okay. This is the dorsal view, posterior view of scapula. So this is the lateral border of the scapula. You know the two muscles arising from the lateral border of the scapula, isn't it? Teres minor above, teres major below. And they are moving towards the humerus for getting inserted. So in this diagram, you will be knowing the orientation, which is medial side, lateral side, superior, inferior, and all, isn't it? Okay. So this is the infraglenoid tubercle, which gives origin to the long head of triceps, fine. And bounded between teres minor, teres major, long head of triceps and humerus, we have three spaces formed in the scapula called as scapular spaces. Okay. Any idea about the number one? What is the space called as number one in this diagram? Yes, it is called as upper triangular space. Okay. Upper triangular space. And what is number two in this diagram? It is quadrilateral shaped. Okay. So it is called as quadrangular space. Number two in this diagram is quadrangular space. Fine. And what is number three in this diagram? It is also triangular shaped, located little below, so called as lower triangular space. So I hope you are clear about the three spaces of the scapula, isn't it? Number 1, 2, 3. Upper triangular space, lower triangular space, in between the quadrilateral area is called as quadrangular space. Okay. So we have to remember the boundaries as well as contents of all the three spaces. Okay. So from this diagram, you can clearly understand. Okay. So if you keep your hands like this, as mentioned in this diagram, as shown in this diagram, you will be easily understand the boundaries and the contents of all the three spaces. So number one is upper triangular space. Number two is quadrangular space. Number three is lower triangular space, isn't it? So when you keep like this, you will be knowing which is teres minor, teres major, which is scapula bone, and which is long head of triceps, and which is humerus bone. In the humerus, in the upper part, we have surgical neck of humerus, and this is the shaft of humerus. Okay. So if you have the orientation of all these things, you can easily understand, okay, what are the boundaries of all the spaces. Fine. So please go through it. It's not difficult to understand. Okay. So try to understand by keeping your hand like this. Okay. Fine. So the content of the upper triangular space, I am marking now. Upper triangular space content is circumflex scapular artery. Okay. So remember the only content of upper triangular space. Okay. That is circumflex scapular artery. Circumflex scapular artery. And what are the two contents of the quadrangular space? You know, quadrangular space is related to the surgical neck of humerus, which is winded around by axillary nerve and the posterior circumflex humeral artery. Okay, these are the two contents of quadrangular space. Then coming to the lower triangular space, you know, lower triangular space is related to the shaft of humerus. In the shaft, we have the radial groove or spiral groove. If you know the two structures related to the radial groove or spiral groove, you will be able to say the two contents of the lower triangular space, namely radial nerve, which is accompanied by profunda brachii artery. Fine. So please go through the boundaries and the contents of all the three spaces of the scapula, otherwise called as intermuscular spaces of axilla or scapula, whatever. Fine. Fine. So the next topic we are going to discuss now is serratus anterior muscle. Okay, it is one of the favorite topics for the examiners. Okay, fine. So in this diagram, you are seeing the lateral thoracic wall. Okay, lateral thoracic wall. Okay, so can you understand from this diagram where is sternum bone, where are the ribs, where is the scapula? Can you understand? Okay, so which is anterior, which is posterior, you will be able to understand, right? So what is the site of origin of the serratus anterior muscle? It arises from starting from here to here. Okay, so it arises from upper 8 ribs. This word is important. It arises from upper 8 ribs by 8 digitations, 8 parts or 8 digitations. Okay, and the muscle fibers are moving backwards to get inserted into the medial border of the scapula. Medial border of scapula along the costal surface, okay. Not only getting inserted into the medial border, it is also getting inserted into the, okay, it is also getting inserted into the inferior angle of the scapula, okay. So it is getting inserted into the medial border of scapula along the costal surface as well as inferior angle. Okay, this is the inferior angle of scapula, fine. And other than origin and insertion, we have to know the nerve supply, action, and applied aspect of the serratus anterior. What is the nerve supply of serratus anterior? Exactly, it is supplied by long thoracic nerve. Okay, it is supplied by long thoracic nerve. So what is the importance of the long thoracic nerve? You know, since it supplies serratus anterior muscle, it is called as nerve to serratus anterior, and it is also called as nerve of Bell. Nerve of Bell, fine. It is also called as nerve of Bell, fine. And please remember, the long thoracic nerve peculiarity is it is not arising from any of the cords of the brachial plexus. It is directly arising from the roots of the brachial plexus. Okay, from the C5, C6, and the C7 roots of the brachial plexus. Okay, it is directly arising from the C5, C6, and the C7 roots of the brachial plexus. Fine. So coming to the two main actions of the serratus anterior muscle, you know this muscle is moving from front to back, isn't it? So when the serratus anterior muscle contracts, it will move the scapula forward. It will move the scapula bone forward. What is the forward movement of the scapula called as? Exactly, protraction of scapula. The forward movement of the scapula is called as protraction of the scapula. Fine. So scapula causes protraction. Serratus anterior muscle causes protraction of scapula, and one more important action of the serratus anterior muscle is it causes overhead abduction of shoulder joint, okay, along with trapezius muscle. Serratus anterior and trapezius muscle both together cause overhead abduction. That means 90 to 180 degree abduction, or you can say more than 90 degree abduction, okay. More than 90 degree abduction or overhead abduction. Okay, so please remember the two main actions of serratus anterior muscle. Okay, since this muscle causes forward movement of scapula, which is important during boxing, this muscle is simply called as boxer's muscle. Okay, so serratus anterior muscle is also called as boxer's muscle. Okay, fine. Now most of the things you are seeing here already we have discussed. You know the three muscles getting inserted into the medial border of the scapula, right? Which are supplied by dorsal scapular nerve, that also you know, right? Out of these three muscles, what is the action of levator scapulae? Yes, it causes elevation of scapula. Okay, levator scapulae causes elevation, that is upward movement of scapula. And the other two muscles, namely rhomboid minor and rhomboid major muscles, they cause retraction, that is backward movement of scapula. R for R. Rhomboid muscles cause retraction of scapula. Fine. Okay. Now coming to the supraspinatus muscle, the action of supraspinatus muscle is initiation of abduction. What do you mean by initiation of abduction? That is 0 to 15 degree abduction of shoulder joint. Okay, 0 to 15 degree abduction of shoulder joint is produced by supraspinatus. So it is called as initiator of abductor. Okay, initiation of abduction. Okay, fine. And the final point about the today's session is remember the actions of latissimus dorsi muscle. What are the three actions of latissimus dorsi muscle? One is it causes extension of the shoulder joint. Dorsal means posterior. So it will move the shoulder joint backwards, called as extension of shoulder joint. And it also causes adduction of shoulder joint and medial rotation of the shoulder joint. So remember the three actions of latissimus dorsi muscle. Okay, fine. The remaining continuation of the topic will be dealt tomorrow. Okay, fine. So thank you all. Thank you once again.
Okay. Yeah. Good evening, friends. So today we will see one ABG, advanced interpretation of ABGs, which are usually asked in INICET. Okay. Yeah. Let's go into the question. The question says, an alcoholic who is continuously drinking alcohol and he is continuously vomiting. Okay. He is altered now. the ABG shows a pH of 7.36 and bicarb of 22, PCO2 of 40, sodium 145, chloride 100, potassium 3.2. So, what is your interpretation in this ABG? A, normal ABG, just treat the alcohol intoxication part. B, high anion gap metabolic acidosis. C, high anion gap metabolic acidosis plus normal anion gap metabolic acidosis. Or D, high anion gap metabolic acidosis with metabolic alkalosis. What is your ABG interpretation? pH, which should be in the range of 7.5 to 7.45. Okay, 7.45. So a single value, if you want to remember, it is 7.4. Next, partial pressure of carbon dioxide 35 to 40. Single value will be 40. Okay. Next is bicarb. Normal values. Hello, can you hear me? Yeah. Yeah. So let's see one interesting ABG today interpretation. Okay. A chronic alcoholic who has been continuously drinking alcohol for the past 10 days and he's continuously vomiting. He's altered now. Okay. His ABG shows pH of 7.36, bicarb of 22, PCO2 of 40, and electrolytes have been given here. What is your ABG interpretation? Is it a normal ABG? You should just treat the alcohol intoxication part. Or is it having high anion gap metabolic acidosis? Or is it having high anion gap metabolic acidosis with normal anion gap metabolic acidosis also? Or is it having high anion gap metabolic acidosis with metabolic alkalosis also? So if you see, this question is aiming to test your advanced ABG interpretation skills. This is how they ask in INI-CET. So first, if you see, as we saw yesterday, we will learn the basics of ABG. What are the basic parameters you should remember? So as we saw yesterday, pH should be 7.35 to 7.45. single value 7.4, PCO2 35 to 40, you should remember, single value 40, bicarb 22 to 24, single value 24. Okay, so if you apply the same step here, let's see, pH, it is 7.36, 7.535 to 7.45 is normal, then that means pH is normal here. Okay, then what about bicarb? It should be 18 to 24. It is within 18 to 24. So that means bicarb is also normal here. Okay. What about partial pressure of carbon dioxide? It is 40. Normal value is 35 to 40. Then it is also normal here. Then can I tell it as a normal ABG and can I move on? Or should I see one more parameter before deciding it is a normal ABG? The parameter which you should always look into is the anion gap. Okay, so usually when we are solving ABGs, first our focus will be on the pH. We will see the pH. If it is less than 7.35, we'll go to acidosis or alkalosis. We'll be seeing. Okay. Then after interpreting, we will see the bicarb and PCO2 value. We will divide it whether it is metabolic acidosis or respiratory acidosis, metabolic or respiratory alkalosis. We will see depending on the values as we discussed yesterday. Then if you see, we will go calculate the compensations. Is it metabolic acidosis means what is the formula used? Winter's formula, PCO2 is equal to 1.5 times the bicarb plus 8 plus or minus 2. It is metabolic alkalosis. Expected PCO2 will be bicarb plus 15. So all these formulas will be applied. Then we will analyze whether it's compensated or not. Okay. But here, if you see, everything is normal. Before calling it as a normal ABG, always calculate the anion gap. Okay. So here, if you see, let's calculate the anion gap for this question. Anion gap is equal to, as we saw yesterday, sodium minus chloride plus bicarb. Okay, so sodium is equal to 145 minus chloride is 100 plus 22. So it will be 145 minus 122. It will be 23. Okay, so what is happening here to anion gap? It is more than 12. Then it is abnormal. Okay, it is abnormality is there. So you can't call this ABG as a normal ABG. First option is ruled out. Let's see why. And what is the role and how to find out the different metabolic abnormalities in this ABG. Okay, so anion gap is more than 12, which is 23. You have found it out. Okay, so what is this anion gap and how to apply this in my question? See, anion gap, if you see, a simple concept. If you see, always the number of cations in your body is always equal to number of anions. So if you take the measurable cations, they tell only sodium is the measurable cation. Even though calcium, magnesium we measure, but still we only take sodium as the measurable cation. See this graph, only sodium is the measurable cation. And if you take the anion side, chloride and bicarb, both are measurable anions. Okay, and apart from chloride and bicarb, there are lots of unmeasurable anions like sulfates, phosphates, proteins, amino acids, all negatively charged particles, all will be coming into unmeasurable anions. So unmeasurable anions is even more. So if you see, there is always a gap that exists between the measurable cations and the measurable anions. So always there is a gap. This gap is the anion gap. Okay. Yeah. So how to measure this? Sodium minus chloride plus bicarb. Okay. So if you apply normal values like 135, 124, you will get a normal anion gap of 8 to 12. Single value you can remember as 12. If it is more than 12, it is high anion gap. If it is less than 12, it is low anion gap. Okay. Yeah. So now I want to emphasize this concept into you. See, any extra acid added into your body, it might be some alcohol, it might be some toxins, any extra acid added to the body will raise the anion gap. Why? Because any alcohols, as we studied in our basic chemistry, that any alcohol when added into the body, it will be oxidized into aldehydes and acids. Final part will be acids. If ethanol is drunk by a person, it will be converted into acetic acid, methanol, formic acid. So all acids will be formed at the end. In the acid, if you see, there will be a negative charged particle, which is the anion, and will be a proton. It will divide into proton and anion. So this proton, what it will do is, it will suck out all the bicarb available in the body. So bicarb will be reducing, and this extra anion will replace the bicarb pool. So they tell whatever bicarb is lost, that is replaced by this extra anions. Okay, because the acid released a proton and an anion. This proton consumed all the bicarb. And in this bicarb area, this extra anions gotten sat into it. So if you see at the end, this gap, if you see, is getting increasing because extra anion gap is increasing. That means increased anion gap. So we can calculate a ratio called delta ratio. Very important. Okay, this is how they ask questions in INICET. Delta ratio is equal to, so what we understood, whatever change in anion gap which is happening will be the change in bicarb. Okay, so normal anion gap we can take it as 12. So any anion gap minus 12 will be 24 minus bicarb. This is the formula for delta ratio. Okay, in our question, the anion gap was 23 and bicarb was 22. Okay, bicarb was 22. So if you see 23 minus 12 by 24 minus 22. So if you see actually some 11 by 2, which is almost 5.5. Okay, so what you should know is this delta ratio, if it is more than 2, it is HAGMA, high anion gap metabolic acidosis plus metabolic alkalosis. If it is within 1 to 2, it is HAGMA only. This you should memorize. And if it is between 0.4 to 1, then it is HAGMA, high anion gap metabolic acidosis plus normal anion gap metabolic acidosis. And if it is less than 0.4, it is NAGMA only. Okay, so this you should memorize, or else you can remember. Actually, conceptually also you can remember. See what I told, whatever bicarb is lost, that much anion gap is increased. So if the ratio is in between 1 to 2, then only HAGMA is happening. Yes or no? Yeah. And if the metabolic alkalosis is happening, meaning your bicarb change, if you see, what will happen to the bicarb change? It will be very less. So the numerator will be very much increased in delta ratio. So more than 2 will constitute hugma plus metabolic alkalosis. Okay, so this you should remember with respect to delta ratio. Okay, so just see the question now. Now we'll calculate delta ratio. What happened? Delta ratio was 5.5, which is more than 2. So it is hugma plus metabolic alkalosis. Okay, yes. So this is the answer. Hugma plus metabolic alkalosis. Yeah. Thank you. Tomorrow we will meet with one more interesting question. Thank you.
Okay, good evening everyone. So today's class today we'll deal with one of the important topics. Okay. So before we start our class, let us see the questions. Which one of the following is a typical feature of chronic extravascular hemolytic anemias? We have 4 options. Okay, we'll look into the options later. Which one of the following is a typical feature of intravascular hemolysis? Okay, and the third question will be, which one of these statements is true regarding hereditary spherocytosis? So we will look into details of extravascular hemolysis, intravascular hemolysis, and then a little about hereditary spherocytosis, hereditary elliptocytosis. Okay, whatever questions are whatever the potential questions are, we'll go through them. So when it comes to extravascular hemolysis, you know that the hemolysis is occurring in the reticuloendothelial system, okay, where the macrophage engulf the RBCs and the RBCs are broken down inside the macrophage. Okay, RBCs are engulfed by the macrophage and they are broken down inside the macrophage. So inside the macrophage, globin is released. Okay, iron, hemoglobin which is released is broken down into globin, iron, and protoporphyrin. Okay, globin is then degraded to amino acids, and the amino acids will be used up for various purposes. Iron is then, which is released from the macrophage, binds to transferrin and it is further reused. Okay, protoporphyrin which is released, it gets converted to bilirubin, taken up by the liver. The unconjugated form is taken up by the liver, then it gets conjugated there, goes into the gut through the portal circulation, okay, and excreted in feces as stercobilinogen, okay, and some of it is reabsorbed into the blood circulation, reaches the renals, and it is excreted as urobilinogen in the urine. All these things takes place in the in case of extravascular hemolysis. So whenever there is extravascular hemolysis, because this is occurring in the reticuloendothelial system, we can expect splenomegaly. Okay, size of spleen is increased, so splenomegaly we can expect. Okay, and we can because the liver is involved, we can expect jaundice, and in case of chronic hemolysis, gallstones, pigment gallstones. Okay, pigment gallstones. When it comes to urobilinogen, because when there is increased amount of hemolysis, increased urobilinogen in the urine, however, bilirubin will not be increased in urine, urobilinogen will be increased. So urine on standing for long duration, what will happen? The color will increase. Fine, that is the thing. Then when coming to intravascular hemolysis, that means the RBCs are broken down within the blood vessel. Okay, RBCs are broken down within the blood vessel. That time hemoglobin is released into the bloodstream itself. Where is the hemoglobin released? The hemoglobin is released into the bloodstream itself. So this hemoglobin later reaches the renals. Okay, this hemoglobin later reaches the renals, and you will see hemoglobinuria and hemosideриnuria. Okay, and then some amount of it is converted to methalbumin. Okay, some amount of it is converted to methalbumin. What is very important in intravascular hemolysis is you will see hemoglobinuria. That is very important. Yes, of course. Then there is something called haptoglobin. Okay, haptoglobin is a polypeptide which is synthesized in the liver. This one will prevent the loss of hemoglobin, okay, whichever is there in the circulation due to hemolysis. How will it prevent the loss of this hemoglobin which is there in circulation? By binding to it. Okay, so haptoglobin binds to hemoglobin and prevents its loss. So whenever there is intravascular hemolysis, there will be hemoglobinuria, hemoglobinemia, and the content, the amount of haptoglobin in the blood will be reduced, because the haptoglobin, whatever is there, it is bound to the hemoglobin. That is one important point. It's a potential question. Okay, and then there is something called hemopexin. Okay, like how haptoglobin binds to hemoglobin, hemopexin will bind to heme in the circulation and prevent its loss in the urine. Okay, this is about intravascular and extravascular hemolysis. Fine. Next. So apart from that, we have to know whenever there is hemolysis, now, so what will happen to the in the peripheral smear? What are the changes we'll find? In the bone marrow, what are the changes we'll find? Before looking into this, we will just briefly see what are the clinical features. So the patient will have pallor. Okay, the patient will have jaundice. Okay, then the patient can have splenomegaly, as I told you. The urine color turns dark on standing because of the presence of urobilinogen, pigment gallstones. Okay, all these are seen. Fine. And specifically in few hemolytic diseases like sickle cell anemia, what will happen? The patient will present with ulcers around, especially the ankle joint. Okay, and in case of thalassemia, they will have bone deformities. The development only, they'll have bone deformities because of the expansion of the bone marrow. Okay, and in case of cold antibody associated hemolysis, okay, autoimmune hemolytic anemia, what will we see? We will see discoloration of the peripheral acral regions of the body, fingers and toes. Okay, so these are special symptoms which we can observe. When coming to peripheral smear, what will happen is in the peripheral smear, we will see the characteristic feature is fragmented RBCs, isn't it? So schistocytes we will see. Along with that, we will see microspherocytes. Microspherocytes are small RBCs without any central pallor. So we will see microspherocytes and cystocytes. What will we see? Microspherocytes and cystocytes. Okay, along with few normocytes. Fine. This is the peripheral smear. When coming to bone marrow, there will be bone marrow expansion because of hemolysis. Okay. One more thing on peripheral smear, we will see increased number of reticulocytosis. Reticulocytosis means increased number of polychromatophilic cells. They are just the immediate precursors of normal RBCs. Okay. So when we do a retic count, it will be in the range of 2 to 5 usually. Okay, or even more. So it will be definitely above 2. Okay, and then when coming to bone marrow, I told you bone marrow expansion. So all that hair on end appearance, all those things will be there. Fine. Along with that, you will see that ME ratio normally is 2:1 to 3:1, isn't it? So this will become 1:1. Okay, ME ratio will be 1:1. Fine. This is one thing. Then next, when coming to common causes, in causes today, I will be concentrating only on hereditary causes of hemolytic anemias. In that, I want you to remember, first thing is membrane defects. Okay, first thing is membrane defects. Under membrane defects, we have HS, HE, hereditary stomatocytosis and Southeast Asian ovalocytosis are there, but they are very subtle. They don't manifest usually. So we have to remember hereditary spherocytosis and hereditary elliptocytosis. Next, we have hemoglobinopathies. Okay, hemoglobinopathies including sickle cell anemia and thalassemias that we will see in detail in the next classes. Okay, and after that we have enzyme deficiency including G6PD deficiency and pyruvate kinase deficiency. Fine, G6PD and pyruvate kinase deficiency. Okay, fine. So now we will see what is hereditary spherocytosis and what is hereditary elliptocytosis. See, hereditary spherocytosis, I told you already that there is membrane abnormalities, isn't it? Hereditary spherocytosis and elliptocytosis, there is membrane abnormality. As the name tells, it both are autosomal dominant. As the name is telling, both are autosomal dominant. Of course, spherocytosis means you will see spherocytes. Elliptocytosis means you will see elliptocytes. Isn't it? So in these both, comparatively in these both, the hereditary elliptocytosis is milder form. Okay, it is milder. The symptoms and hemolysis is milder. Okay, and this in hereditary spherocytosis, vertical interactions of the, see, you just go through the RBC membrane proteins, okay, that has pectin, ankyrin, protein 4.2, 4.1, band 3, all these things are there. Just open your Robbins and go through that. Along with that, you have to know one important point, that there is a vertical impairment. Okay, vertical interaction impairment in in the membrane. Okay, when there is vertical interaction impairment in the membrane, it will lead to hereditary spherocytosis, and here it is horizontal interactions. That much you have to remember. Okay, horizontal interactions. Okay, apart from this, one more thing you have to remember is, which is the most common membrane protein which is deficient in hereditary spherocytosis? It is ankyrin, most common. Okay, spectrin is the next. Spectrin actually is the third. Band 3 is the next, and then it is spectrin. But anyways, that will not be a question for you. Which is the most common is a potential question. What is the importance of spectrin deficiency? Is the degree of hemolysis correlates with spectrin defect. The more is the spectrin defect, the more is the hemolysis. Okay, especially amongst these, if there is spectrin defect, the hemolysis is more. Fine. Next, band 3 abnormalities. Okay, band 3 abnormalities can occur. Pallidin abnormalities. One important point here, that is pallidin or protein 4.2 abnormalities. We have to know that only this is autosomal recessive inheritance. Only this is autosomal recessive inheritance. Fine. Glycophorin is one membrane protein which is never affected. Glycophorin is one membrane protein which is never affected. Next, in case of hereditary elliptocytosis, I just want you to remember that spectrin is the one which is mutated in it. Okay, spectrin abnormalities, especially beta spectrin. Okay, it can be defect in the formation of homodimers of spectrin itself or heterodimers of spectrin and ankyrin. Okay, and one point I want you to remember here is Southeast Asian ovalocytosis. There is one entity when there is band 3 deletion. Okay, it is caused when there is band 3 deletion, and in those cases you see something called pincer cells. Important question. You see something called pincer cells. Fine, you see something called pincer cells. So in both these hereditary spherocytosis, the manifest signs and symptoms, hemolysis is more. Hereditary elliptocytosis, it is milder. Okay. Apart from these both, there is something called hereditary stomatocytosis. In stomatocytosis, the RBCs will have a mouth-like opening. That is why it is called stomatocytosis. It can be of two types: xerocytosis and overhidrosis. Okay, in xerocytosis type, there is actually defect in the membrane lipid protein. Okay, so what happens here is, that is not important for you as a question, that is too much in detail. So in xerocytosis, you have to know that the osmotic fragility is decreased. Okay, here in overhidrosis, it is band 7.2 which is defective. Here, osmotic fragility will increase. So in stomatocytosis, if they in general ask you stomatocytosis, you will write osmotic fragility will be decreased. Okay, if they particularly ask overhidrosis, it is increased. So stomatocytosis has two types. Fine. And in the previous slide, I told you that band 3 protein defect will lead to what? Southeast Asian ovalocytosis. That actually, this stomatocytosis and Southeast Asian ovalocytosis don't manifest with much. Okay, they are very mild. But what one point which is important is, in Southeast Asian ovalocytosis, pincer cells is one point. Second point is they are resistant to malaria. Okay, they are resistant to malaria. So what is the investigation of choice? Investigation usually before it was osmotic fragility was the preferred thing. But now we do flow cytometry with eosin 5 maleimide. Okay, eosin 5 maleimide. So this is going to measure the content of membrane proteins. Okay, especially band 3. So whenever the content is reduced, the graph will be reduced, and hence we cannot tell particularly which protein, when membrane protein is defective. Mostly this is eosin 5 maleimide will bind to band 3. But it is not going to exactly tell you it is band 3 defect or ankyrin or spectrin. It will just tell you there is membrane defect. That's all. Okay. So it is little better than osmotic fragility. Fine. If they ask you, this can be a question. This curve can be given, and what does it detect? It will detect membrane abnormalities, membrane structure defects. Okay. So on peripheral smear, if you observe this smear, see these are all microspherocytes which are seen. So in hereditary spherocytosis, actually when they are formed, they are biconcave and normal. gradually, as they age, some amount of membrane is pinched off in the spleen, leading to spherocytes. Okay, this is hereditary spherocytosis. See here, many elliptocytes you are able to see. Okay, so this is an image of hereditary elliptocytosis. See here, this is hereditary stomatocytosis. Fine. Okay, then next. Yeah, for all, especially for HS and HE, the treatment is splenectomy. And because there is hemolysis, folic acid. Okay, these both the patient will do well. Usually, when only we see moderate and severe hemolysis, we do splenectomy. Okay, because considering its morbidity associated with capsulated organism infection. Right? Then, so with this basic, we'll just answer these questions. Which one of the following is typical feature of chronic extravascular hemolytic anemias? So, a raised serum conjugate bilirubin, okay, then low reticulocyte count. So this is ruled out. Whenever there is hemolysis, there is no low reticulocyte count, because reticulocyte count is going to be increased. So that option is ruled out. Okay. Hypocellular bone marrow, no, bone marrow expansion occurs. So the bone marrow will be hypercellular with ME ratio 1:1. So this is ruled out. Okay. And then risk for gallstones. Yes, this you have a doubt and this you have a doubt. It is raised serum unconjugated bilirubin, because there is excess of bilirubin produced. The liver is not able to conjugate. So this will be a wrong option. Okay. And so risk for gallstones will be increased. Okay. On chronic extra, especially see, they have given a point called chronic. So the risk for gallstones are increased. Which one of the following is a typical feature of intravascular hemolysis? See, positive Coombs test is a feature of autoimmune hemolytic anemia. So this is ruled out. Hemosiderin in urine, yes. This you have a doubt, keep it aside. Elevated haptoglobulin level, whenever there is intravascular hemolysis, I told you haptoglobulin binds to hemoglobin, so there will be reduced haptoglobulin level. So this is ruled out. Raised serum bilirubin is usually a feature of extravascular hemolysis. So hemosiderin in urine, hemosideриnuria, hemoglobinuria, metaalbuminemia, hemoglobinemia is a feature of intravascular hemolysis. Fine. Which one of these statements is true regarding hereditary spherocytosis? It is caused by inherited defect in hemoglobin. No, it is hemoglobinopathy. So this option is wrong. It is more common in males. I didn't tell you any preference. So this option is also going to be wrong. It can be treated by splenectomy. Yes, so it can be treated by splenectomy. All the above option is wrong because the other two options are wrong. Fine. Thank you.
Okay. So we'll be dealing three important topics today. One is Streptococcus, Enterococcus, and Neisseria. We'll start with Streptococcus. You can see in the picture, they are gram-positive cocci in chain. Okay. So how we classify Streptococcus? First, on the basis of their oxygen requirement, we say them aerobe and facultative anaerobe or obligate aerobes. Obligate anaerobes. So obligate anaerobe, example is your Peptostreptococcus, which is obligate anaerobe. So aerobe and facultative anaerobe, we further classify on the basis of hemolysis on 5% She blood agar. Okay, so you have alpha hemolysis, which is called partial hemolysis. You have gamma hemolysis, which is called complete hemolysis. Sorry, beta hemolysis, which is complete. Gamma, which is non-hemolytic. So you have alpha, beta, gamma hemolysis. Alpha is partial hemolysis. I will show you the picture. So this first picture is beta hemolysis, which is complete hemolysis. Gamma, which is partial hemolysis. So on partial hemolysis, you get green color discoloration. Okay. And your gamma is non-hemolytic. So you are not seeing any hemolysis when you put the Streptococcus coli on blood agar. 5% sheep blood or human blood can be used for culturing Streptococcus. As we know, Streptococcus is fastidious. So it cannot grow on the simple media, nutrient agar and other media. It needs blood agar or chocolate agar to grow. So we saw how the alpha hemolysis, partial hemolysis looks, beta hemolysis and gamma hemolysis look. Now, as we saw, it shows greenish discoloration. Now, if you see alpha hemolysis, you will check for optochin sensitive. OP disc, optochin sensitive. If it's sensitive, it's Streptococcus pneumoniae. So sensitive will be your pneumonia. If it's resistant, it will be your viridans or sanguis or Streptococcus mutans. So these are alpha hemolytic Streptococcus, but they are optochin resistant. Sensitive is pneumonia, resistant is your viridans, sanguis or mutans. Viridans and sanguis is responsible for subacute bacterial endocarditis, okay, and mutants, which causes dental caries. Beta hemolysis, which is complete hemolysis, and most of the human pathogen belongs to beta hemolytic Streptococcus, which we classify. We have one classification which is called Landsfield classification. Okay, on the basis of C carbohydrate present on the cell wall of the bacteria. So Landsfield classification gives 20 types, A to V except ING. So among that, group A is your Streptococcus pyogenes, which causes pharyngitis, rheumatic fever, glomerulonephritis. This group group A, which is Streptococcus pyogenes, is further classified on the basis of M protein, which is called Griffith classification. Okay, Griffith classification classify them into 1 to 80 groups. Okay, now, so two classification we learn in beta hemolytic Streptococcus. One is your Landsfield classification, which classify into two serotypes, A to V except INJ. And that group A is further classified on the basis of M protein, which is called Griffith classification, that is 1 to 80. Okay. Gamma non-hemolytic is your Enterococcus. Enterococcus sometimes can show, apart from non-hemolytic, it can show gamma or beta hemolysis also. So we saw beta, gamma, and alpha hemolysis. We saw beta hemolytic. We learned about alpha hemolytic, optochin, and other thing. We'll start with beta hemolysis. Beta hemolysis is complete hemolysis. You have Streptococcus pyogenes. More pathogenic organism in beta hemolytic is pyogenes and Agalactiae. Pyogenes will be bacitracin sensitive. Okay. Okay, which is your group A. So group A, beta hemolytic, you can further classify on the basis of bacitracin sensitive. If it's pyogenes, it will be bacitracin sensitive. If it's resistant, it is Agalactiae. Apart from that, we'll see gamma hemolytic. We have Enterococcus. The species will learn Fecalis and Faecium, two species, which is more pathogenic to human. Then alpha hemolytic, you have pneumonia and viridans. If it's optochin sensitive, it's pneumonia. If it's resistant, it's viridans. Bile-soluble will be pneumonia. I will show you the picture how the bile-soluble looks. If it's non-bile-soluble, it is your viridans. Capsulated will be pneumonia. Non-capsulated will be your viridans. So these are the differentiating point how we classify alpha, beta, gamma further. So beta, we use bacitracin. Alpha, we used two optochin we used. Then we used bile solubility. And then we use capsule, that is quelling reaction. Okay, so if it's these all three are positive, it's pneumonia. If it's negative, it's virulence. So I have shown you this picture. Okay. Okay. Now we learned, like besetracin sensitive is your group A, resistant is your agalexia, right? Among resistant, if it's CAMP positive, CAMP is, this is your CAMP test. Okay. So this is your CAMP test. Okay. Which we say Christie-Atkin-Munch-Peterson test. Okay, the short form is CAMP test. If it's CAMP positive, this is your CAMP test positive, where you streak Staphylococcus aureus beta hemolytic strain on the center, and perpendicular you streak the testing strain. Okay, if you see broad arrow-shaped hemolysis, it is positive for Christie-Atkin-Munch-Peterson test, that is CAMP positive, that is your Streptococcus agalexia. If it is negative, this is your negative. If it's negative, it is your other group, group D, okay, not A and B. A is your pyrogens, and your, because of besetracin, you have already divided. Now besetracin resistant, you dividing on the CAMP basis, CAMP positive agalexia, and negative is your possibly group D. Now, which all are medically important streptococcus? We learned, right? Pyogens, which causes pharyngitis, rheumatic fever, acute glomerulonephritis, agalexia. Agalexia is one of the very important cause of neonatal meningitis. Okay, Enterococcus fecalis, which grows in high concentration of sodium chloride, and it causes endocarditis, UTI, biliary tract infection commonly. Viridans, which causes dental caries, endocarditis, subacute bacterial endocarditis. Pneumonia, which causes pneumonia. So these are the virulence factor of Streptococcus pyogenes. The short, we can remember a mnemonic: smashed. Streptolysin, M protein, anti-C5 peptidase, streptokinase, hyaluronidase, exotoxin, DNase. These are the pathogenic factor or virulence factor of Streptococcus pyogenes. Streptococcus pyogenes, the structural component cross-react with human tissue. So hyaluronic acid is present in Streptococcus. So this is the picture. Capsule will have hyaluronic acid. Okay, so this will cross-react with human synovial tissue, which is present in synovial, which is present in our knee. Cell wall protein. Cell wall protein. Okay, this will be cell wall protein that will your cross-react with myocardium. Then cell wall carbohydrate. You will have carbohydrate on the cell wall. Okay, carbohydrate will be present, which will cross-react with cardiac valve, heart valve. Then cytoplasmic membrane antigen will cross-react with vascular intima. Peptidoglycan will react with skin antigens. Okay, so these are the factors, virulence factor, which have learned. We'll learn streptokinase now, which is the enzyme. First enzyme we'll learn streptokinase. Streptokinase has medical importance because it lyses the blood clot. It is responsible for rapid, also responsible for rapid spread of organism. So IV injection of streptokinase we used for the treatment of pulmonary emboli, coronary artery thrombosis, and venous thrombosis. So it has a very much medical importance. Streptokinase we also call as fibrinolysin. Now streptodornase, which lyses the DNA and causes thinness of the pus or discharge. Then hyaluronidase, this also acts as a spreading factor. So the enterococcus has spreading nature of infection, which is because of hyaluronidase. Then C5 peptidase is there, which help in phagocytosis, which inhibits, prevent the phagocytosis of streptococcus. Then you have streptolysin O. O is oxygen labile. S is oxygen stable. S for stable, just remember. O is oxygen labile. And streptolysin O, that is anti-streptolysin O titer. We check if it's more than 200. It gives a clue towards rheumatic fever. Okay, so ASO titer, streptolysin O titer, we check for rheumatic fever, rheumatic heart disease. Then streptolysin S you have, which is stable. Okay, so streptolysin O resembles other hemolysin, oxygen labile hemolysin of Clostridium perfringens, Clostridium tetani, and Streptococcus pneumoniae. So this is your exam question. Streptolysin O resembles which other hemolysin? Clostridium perfringens, Clostridium tetani, and Streptococcus pneumoniae. So pyrogens causes suppurative, non-suppurative infection, pharyngitis, impetigo. Impetigo is skin lesion, pneumonia, necrotizing is a flesh-eating bacteria. Because of that, pyrogens is called as flesh-eating bacteria. The infection spreads very fast. Okay, cellulitis, then bacteremia, otitis media, sinusitis, meningitis. Then non-suppurative, we have rheumatic fever or rheumatic heart disease and acute glomerulonephritis. So this is the erythrogenic toxin or pyrogenic toxin released by Streptococcus, and it causes scarlet fever. Now we rarely see this cases, but this is super antigen. We have to learn this importance. This is super antigen, which causes massive release of cytokines, and it activates T cells. Okay. Now coming to Streptococcus pneumoniae, as we can see in the picture, they are lanceolate shaped. Okay, and they have a capsule. This you can see the covering, that is the capsule of Streptococcus pneumoniae. So, and this capsule you can see in India ink, which we have learned earlier. India ink is done for capsule demonstration. Okay. And Streptococcus pneumoniae, as we have learned, it is alpha-lytic, so it shows green color discoloration on blood agar plate, and Draughtsman appearance. Draughtsman appearance we see in Streptococcus pneumoniae colony, when after 48 hours of incubation, colony starts dipping in the center. It's because of autolysin enzyme produced by Streptococcus pneumoniae. Now, what are the other virulence factors of Streptococcus? You have capsule polysaccharide, which prevents phagocytosis. All the capsulated organism, capsule prevent phagocytosis. It has pneumolysin, which damages the membrane. Okay, then autolysin, which releases the bacterial component in the infected tissue. And this autolysin is responsible for Karam-Cohen colony or Draughtsman colony. So this is the optochin. When you put optochin disc on the plate, it is sensitive. And bile solubility test. This is the bile solubility test. Streptopneumonia, it will be positive. Inulin fermentation, this is positive. So inulin fermentation will be positive. So optochin sensitive, bile solubility positive, and inulin fermentation will be positive in Streptococcus pneumoniae. Then this is quelling test, which is capsular swelling reaction. When you use anti-sera, anti-capsular antibody will be there. When you use anti-sera containing anti-capsular antibody, capsule will swell. That is called quelling reaction. So you have pneumococcal vaccine, 23 valent pneumococcal vaccine and conjugate vaccine. Two vaccine, polysaccharide vaccine and conjugate vaccine you have. The polysaccharide vaccine is called PPSV23 and conjugate vaccine is called PCV13. It has 23 serotype, it has 13 serotype. And 23 is less immunogenic and this is more immunogenic. And it has protein conjugate as an adjuvant and it is very effective for the children less than 2 years. This we cannot use in a children less than 2 years. PPSV, a polysaccharide vaccine, less immunogenic, it's shorter duration, 3 to 5 years, longer duration. This is effective for carrier state. This is not effective. It can be used for more than 65 year or 19 to 64 year age group with risk factors. I will tell you which all are the risk factors, and this can be used in the children as a primary immunization. So which are the risks? Alcoholic, smokers, heart-lung disease, cochlear implant, CSF leak patients, splenic dysfunction, asplenic patients, sickle cell disease patient, chronic renal failure patient. These all are high risk group for streptococcal vaccine. So in that, what vaccine you have to give, this slide shows how much duration you have to give. So after what you will give PCV, okay, and 2, 4, 6 months booster dose you will give 12 to 15 months. Now coming to enterococcus, enterococcus is bile esculin positive, okay. Group D, they belong to group D. Now they have been separated. We separately also tell it as a enterococcus. Earlier they were placed in the group D. They grow in 6 to 6.5% of sodium chloride, grow at higher temperature also they grow well, and they ferment pyruvate. If they ferment pyruvate, they are Enterococcus faecalis. If they don't, they are Faecium. Okay. So bile esculin positive is their very important feature. This picture you can see, this is bile esculin positive, and they can grow in 6.5% sodium chloride. If they ferment pyruvate, they are faecalis. If they don't ferment pyruvate, they will be Faecium. Neisseria gonorrhoeae, which is diplococci, kidney shape, and they are gram negative. Okay, you can see the picture. They are pink in color. Pink color means they are gram negative. Gram negative diplococci, kidney shape, and they are intracellular. Their culture media, selective media for Neisseria is Thayer-Martin media. They can also be cultured on chocolate agar. If the specimen is non-sterile, we prefer Thayer-Martin media, which is a selective media. So they causes urethral infection, urethritis. This year NEET question you had, similar picture was given and it has been asked which organism it can be. So it is Neisseria gonorrhoeae. And inflammation of periurethral tissue can happen, and multiple discharging sinus can be seen, which is called water can perineum. Please remember, water can perineum is seen in Streptococcus pneumoniae. In women, it causes vulvovaginitis, salpingitis, inflammatory diseases. Drug of choice for Neisseria gonorrhoeae is your ceftriaxone for uncomplicated gonorrhea. Please remember, this also has been asked plenty of time, what CDC recommends for uncomplicated gonorrhea. Now meningitis. So meningitis is also gram-negative diplococci. Thayer-Martin is the culture media. They are oxidase and catalase positive and ferments maltose. Please remember, ferments maltose. And they causes, I will show you the picture, then you will understand better. They have virulence factor, capsule, and pili. This is oxidase test. This near NEET question also, you have been given oxidase. So this the oxidase test looked like, okay? If it's positive, you get bluish purple reaction within 10 seconds after using the test reagent. So few organisms are oxidase positive. One of them used Neisseria, meningitis, apart from the question which was in NEET about Pseudomonas, which is this. So this is the oxidase test. So this is your Waterhouse-Friderichsen syndrome. You can see it present as purpura, okay? It is nothing but meningococcemia. When Neisseria meningitis comes in the bloodstream, you see this Waterhouse-Friderichsen syndrome, where you see purpura throughout skin. Apart from that, it will be having hypotension, adrenal cortical hemorrhage, and DIC. So treatment of choice is IV penicillin, chloramphenicol, third generation cephalosporin can be used. Prophylaxis for the contact is rifampicin and ciprofloxacin. Vaccine, you have monovalent and polyvalent capsular polysaccharide vaccine for group A, C, W135, and Y. Thank you.
Yeah, hello. We'll start again with respect to forensic medicine. So yesterday we were all dumped with a lot of indices, right? So today I'll make it more refreshing and more interesting to you. See, today I'll be showing you pictures, right, for the toxic plants and their fruits and seeds. So the recent trend in INICET is image-based question, right? Yes, particularly with respect to toxicology, you'll get a lot of images with respect to plants, right? Plants, seeds, etc., right? And in the last 2 to 3 years, the image-based plants-based questions were in match the following question. So not only one plant or two plants, you have to choose between 4 or 5 and arrange or match the following correctly, right? So I'll be showing you all those toxic plants, right? So we'll go to next slide, right? So next slide, please. Yes. So out of the plants, so one group of plant is called toxalbumin, right? One group of plant is called toxalbumin. So toxalbumins are nothing but they contain a protein, right? Protein. Albumin is protein, nothing but protein. They can precipitate agglutination, right? RBC agglutination. Just know it can bring about RBC agglutination, right? Yes. So we'll see one by one. And second one is group of plants that are used for artificial brew. You take the plant, make a juice out of it, and place it on the body, surface of body. It will produce brew. It is called artificial brew, right? So we're not going into the details of those theory parts. So I'll show you only photos. So the next slide, please. Yes. Next slide, please. Yes, the slide has come. See, please remember, this is the most repeated toxicology seed, right? Most repeated toxicology seed. See, seeds of Ricinus communis, castor bean, right? Castor bean or castor seeds, right? So one important point to identify the seed is the seeds will be brown, shiny, right? Shiny brown. You could see the shiny seeds, brown, shiny seeds with a variegated appearance, right? A pattern, a crisscross pattern or a variegated pattern, right? So the pattern will be on the seeds, shiny, brown, patterned seeds, right? It's called resinous seed or castor seed or castor bean. Right? Another photo in the same slide is the fruits of resinous will be clumped together, right? Clumped together. See, this is an important point of differentiation between fruits of resinous and fruits of datura. See, datura fruit will be solitary, single, right? Whereas resinous will always be clumped together, right? Resinus communis. You can remember cum means lot. Cum means meeting, right? Communication is meeting. So cum means a lot of. So resinus communis will be clumped, right? Clump of fruits, right? So remember, dark brown shiny seed, resinous seed, right? Resinous seed. So the seed is also called as a seed with having palm of Christ appearance. Palm of Christ appearance. Though the pattern on the surface of the seed is called palm of Christ appearance, right? Palm of Christ appearance. So we'll go to the next slide. So next slide, we have one more seed. Yes. So look at this slide. Look at this slide. See the seed that you have just witnessed, the resinous seed, and this seed, it is nothing but croton tiglium seed. They look alike. They are exactly alike. See, even the textbooks would define croton tiglium plant and croton tiglium seed as they resemble exactly like resinous seeds, except they are dull, right? Except they are dull. See, resinous seeds, shiny, brown. Croton seeds are brown, at the same time they are dull. They're dull. So same pattern may be present in croton tiglium. Same pattern as that of resinous may be present in croton tiglium. The only point of difference between resinous and croton seeds is croton seeds are dull, right? Dull brown. So resinous seeds, shiny brown. Croton seeds, dull brown, right? So never forget, right? Never forget. Yes. Then the next slide. Yes. Next slide, please. And next slide, you would easily identify, right? You can easily identify one of the easiest image-based question in forensic medicine. The red seeds, red black seeds, right? Seeds of Abrus precatorius, right? the red black seed. It's nothing but seeds of Abrus precatorius. Yes, please switch on the animation, please. So it is in the bigger picture, you could see red black, right? Red black Abrus seeds, right? See, another important point I would like to tell you is, see, Abrus precatorius usually would be red with black, right? Red with black, right? Attractive, right? Also remember, Abrus precatorius could be pure white, pure white. It could be pure black, right? It could be pure white, pure black, or it could be green, green with black, right? Green with black. So most common Abrus precatorius photo that you get in an MCQ is this red and black, right? Red and black. So don't worry about it. But less commonly, Abrus precatorius could be pure white or pure black, or rarely it could be green with black, right? Green with black, right? Yes. One clinching point with respect to Abrus precatorius is all seeds will look exactly of same size, right? Abrus seeds will be of same size, right? Same size and weight. Yes. So we'll go to next slide. Next slide, please. Next slide is the loss of toxalbumin, right? The loss of toxalbumin. See, toxalbumin, I told you 4, right? 4 toxalbumins. So first toxalbumin is resin, Resinus communis. Second toxalbumin is croton from Crotontiglium. Third toxalbumin we just now saw, Abrus precatorius, Abrin. And the fourth toxalbumin is Jatropin from Jatropha curcas, right? Jatropha curcas plant. See, this Jatropha curcas plant seeds are so easy to identify. They are pure black, lengthy seeds, lengthy black seeds, right? Lengthy black seeds, right? Abrus, if it is in pure black form, Abrus will be round or oval, right? And same size. Whereas Jatropha elongated black seeds, right? Jatropha curcas, right? Jatropha curcas. So only 4 are the known plant toxalbumins in India. Only 4 known toxalbumins. If there is a point with 3 or 4 keywords, you have to be careful. A potential site for MCQ, right? So resin, croton, Jatropin, Abrin. Only 4 known plant toxalbumins in India, right? So then we'll go to next slide. So next slide we have, yes, please finish the animation, please. Animation, yes. So the first plant is Calotropis. Yes. Animation, please. Yes. Calotropis. Yes. Calotropis. See, whether it is Calotropis procera or Calotropis gigantea. So don't worry about the names. Procera and gigantea differs only in shape of the flowers, right? Shape of the flowers. So there is no much difference between these 2 species. So Calotropis or Madar, M-A-D-A-R, enough, right? So what is this Calotropis used for? Calotropis together with Plumbago or Semicarpus anacardium, right? These 3 are more commonly used for producing artificial buoy or artificial contusion, right? So I told you earlier, so I'll repeat again. Take extract or juice from the plant, rub it on the surface of the skin will immediately turn red, right? Red. Immediately the skin will turn red with blisters around it, right? So one point of difference between true bruit and artificial bruit is artificial bruit will have vesicles and lot of itching, right? Lot of itching. Another point of difference, repeat MCQ, a point of difference between true bruit and artificial bruit. So artificial bruit will have lot of vesicles and itching, right? Another repeat MCQ, right? So we'll get back to the picture, Calotropis picture or Madar plant picture, right? Calotropis, right? Calotropis. Okay. Then we'll go to the next slide. Yes. Please pay attention. Please pay attention. You would not see this picture in any of the standard textbooks, right? Because it is so rare to witness a bloomed Plumbago, right? A bloomed Plumbago. See, Plumbago zeylanica, Plumbago indica, or Plumbago rosea, so all 3 different species. So don't worry about the species and all. If you see the word Plumbago or leadwort, right? Leadwort, L-E-A-D-W-O-R-T, leadwort, right? Plumbago or leadwort. So this plant, you could see, right? You could see distinct flowers, right? Like petals are distinctly placed. So don't worry. Plumbago photo is not present in standard textbooks. So if a slender picture, a hand-drawn picture is given, it has to be Plumbago, right? It has to be Plumbago. So I'm giving a shortcut to identify Plumbago plant, right? So then the third plant is Semicarpus anacardium. We'll go to the next slide. Semicarpus anacardium, which is nothing but marking nut, right? Next slide, please. Yes. The animation, please. Yes. So Semicarpus anacardium or marking nut. So those who have attended NEET, recent NEET, would have easily identified the seed, right? One of the questions in NEET, recently conducted NEET. The question was the toxic principle present in this seed, right? Resorcinol and bilvanol, right? Bilvanol. See, name of the marking nut tree, the Semicarpus anacardium, is binomial name, scientific name. Common name is marking nut, right? In Marathi or Hindi, we call it bilvanol tree, right? Bilvanol tree. So the principle, toxic principle is bilvanol, right? Bilvanol, right? So marking nut, right? Semicarpus anacardium or marking nut. So I repeat, Calotropis, Semicarpus anacardium, and Plumbago. These three are used for artificial buoy or artificial contusion, right? Yes. So never forget marking nut. One of the repeat question after resinous. See, resinous is the most common repeated seed with respect to MCQ, image-based MCQ. Next to most repeat is marking nut, right? Marking nut. Yes. So we'll go to the next slide. So next slide. Yes. Finish the animations. Yes. Okay. 2 more animations are there. Okay. So this plant, you see, like rays of the sun. So in younger days, how do we draw a sun? We'll make an arc and we make 3 distinct lines to draw a sun, right? Exactly in that way, the leaves, the leaflets are arranged. So the unique leaves of cannabis. Once you see this leaf structure, you will never forget. All right. So cannabis, cannabis. So please go for the animation. Yes. See, another repeat MCQ is bong, right? Bong. What we drink in lassi, right? Lassi they used to add bong, right? Bong is nothing but preparation of cannabis, right? Preparation of cannabis. So bong, right? Drinkable in lassi. The next one is charash. Charash is a black solid substance or extracted from cannabis used for preparing sweets, right? Sweets. Or even charash is used for abuse, right? Okay. Then what we smoke is ganja. See, please remember, cannabis is plant's name. Cannabis indica, right? Cannabis indica is Indian cannabis, Indian variety of cannabis. So cannabis is the plant's name. So if cannabis preparation is added into any liquid like lassi or juice, it is called bong, right? Bong. So image of a juice or a buttermilk will be present in the MCQ, right? Next is charash. Please go for the animation. So charash is nothing but a black moss. It is either used for smoking or used for making a sweet, right? Okay. Then the third one, the below mentioned photo, you have the chilam, right? The chilam, the sadhus in UP and all in Himalayan ranges, they used to have this chilam used for smoking cannabis. The smoking form of cannabis is called ganja, right? Ganja, right? So what is the toxic principle present in cannabis? Tetrahydrocannabinols, right? Cannabinols. See, cannabinols would be converted to delta-9 tetrahydrocannabinols, right? So THC cannabinols need to be converted to delta-9 tetrahydrocannabinols. These delta-9 tetrahydrocannabinol is the functional or toxic principle in cannabis, right? Okay. So this conversion from cannabinol to delta-9 tetrahydrocannabinol needs either heating, smoking, right? Through smoke, we are heating it, or needs gastric acid. You have to eat. So either you have to eat cannabis or you have to smoke cannabis. See, why I am stressing this point is we have a question on cocaine where a photo, I'll show you the photo. The photo will be on snorting, right? Taking cocaine through nose. So that is one point of differentiating between cannabis and cocaine. So cannabis, either we have to eat cannabis or we have to smoke cannabis, right? Whereas snorting is unique only to cocaine, right? I'll show you a photo, don't worry. So this is cannabis, hallucinogen or deliriant, either way, mostly hallucinogen, or deliriant, depending upon the choice of MCQ. So bong, charash, or ganja form, right? Yes. So we'll go to the next slide. So next slide is datura, right? Datura. See, datura is called the deadly nightshade. Deadly nightshade, right? Deadly nightshade, thorn apple, devil's trumpet, right? Other names, right? Thorn apple, devil's trumpet. So I told you, right, while explaining resinous communis, I told you, right, how to differentiate resinous communis fruit, because resinous communis fruit will be clumped. You saw in the photo, clumped, more fruits in the same stalk, right? So clumped together. Whereas datura will be solitary, only one fruit, right? Only one fruit, and it will be pretty round. It looks exactly like an apple, green apple, Kashmiri green apple with thorns. So that is why it is called thorn apple, right? Thorn apple. So solitary fruit with thorns in it, thorn apple. And the flowers will be white, datura alba, white. It could be datura metal. Metal means black flower. Mita means what? Black, right? So datura alba is white. Datura metal is white flower with black lines in it, or black stripes in it, you can say, or patch in it, you can say. Or there is one more thing called datura stramonium. Datura stramonium is also white flower, basically with pink stripes on it with a different shape. Only shape is different with respect to datura stramonium. So just know the names. Datura alba is white flower, datura metal, black flower, white with black, and datura stramonium is the same, white with black or white with blue with a different shape. So thing to remember is datura blooms only in night. You can always see this is another important point or important clue to detect what the answer is. So you could see in the top corner, datura was filmed inside a room because it blooms only in the shade. So if it is the photo is taken in the open, the background will be night background, right? Night background. So datura, deadly nightshade, right? And the seeds of datura are given right next to it, which is one of the common differentiating point between chili seed and datura seed, repeat MCQ. That we'll see in upcoming sessions. We'll see. So we'll go to next image. Yes, next slide, please. Yes. So next slide, please. Yes. Yeah. So this is, yes, please press on the animation. Yes. Yes. So this is poppy capsule, right? Poppy capsule. Poppy is nothing but opium, right? Opium. So this is natural opium. So poppy, Papaver somnifera. The seeds present there are called poppy seeds. In common words, we say kasa seeds, right? Kashkash seeds used in biryani and all, right? Kashkash seeds. See, one important point to remember with respect to image-based questions, the kashkash seeds or poppy seeds have no narcotic property. I repeat, no narcotic property. There is no narcotic property in poppy seeds, right? Yes. So remember, a poppy capsule will be made, small linear cuts will be made to extract the juice of opium, natural opium. From that, we can go for morphine production, right? For treatment purposes. Yes. So shall we go to the next slide, please? So yes. So we'll take this slide to be the last slide of the session. So this slide is an important slide, an image-based MCQ in GPMR. See, this is called snorting, right? Snorting is nothing but directly inhaling powdered form of a drug, right? Powdered form of a drug. So white powder, cocaine. White powder is cocaine, right? White powder is cocaine. So cocaine is abused in this way, right? In this way, right? Cocaine, right? Cocaine. So snorting, the answer is snorting. The image of this is given. We are asked to find out which way of abuse is this. Which way? The way is called what, right? Answer is snorting. So please remember the plans we have gone through, or we can make it a revision even in the next session. So we'll stop here. So tomorrow we'll continue from here and complete the rest of the plants and animals with respect to image-based questions in toxicology, right? Thank you.
Yeah, please enable my video. I'm not able to start the video. Please enable my video. Yeah. So, yeah. Yeah. So, yeah. So, good evening, everyone. Today we'll start with retina. So, two important topics we'll be discussing today. One is the diabetic retinopathy. The second topic is FFA. Okay, so we'll be discussing about diabetic retinopathy and FFA today. So, these are very important from the exam point of view. So, before we start FFA, a few points about FFA. What is FFA? FFA stands for fundus fluorescein angiography. It is the study of the normal vasculature of the retina and the choroid. Okay, it is for the study of the normal vasculature of the retina and choroid. Retina and choroid. Okay, so you have to remember that the antecubital vein is the site of injection. In site of injection, we can either use 5 ml of 10% fluorescein, or we can use 10 ml of 5% fluorescein, or 3 ml of 25% fluorescein. So this also they have asked in one of the AIMS questions. So we can either use 5 ml of 10% fluorescein, 10 ml of 5% fluorescein, or 3 ml of 25% fluorescein. The most common used is 5 ml of 10% fluorescein. So we have to know a few terms in FFA. Before we go to FFA and the images, I'll discuss all the terms which are important from the exam point of view. First, we have to know what is pooling of the dye. What does pooling of the dye mean? Pooling of the dye means accumulation of the dye in closed spaces. Okay, so the dye accumulates in closed spaces. Okay, so example, if there is an RPE detachment like in CSR, the fluid accumulation is in subretinal. Okay, RPE detachment in CSR, the fluid accumulation is subretinal. In a PED, the fluid accumulation is sub RPE. Okay, this they have asked. So the fluid accumulation is sub RPE in PED, and the fluid accumulation is a subretinal fluid accumulation in central serous choroidopathy. The second point we should know is what is a leakage. What does leakage stands for? So whenever the dye escapes into an open space, what is the open space we have in the eye? So if the dye escapes into the vitreous cavity, so in case of proliferative diabetic retinopathy, when the patient has a vitreous hemorrhage, the dye can escape into the open space, mainly the vitreous cavity. The third one is the window defect. So what is window defect? Window defect, remember, it is the early hyperfluorescence. This is due to the RPE atrophy. Early hyperfluorescence due to the RPE atrophy is called as window fluorescence. The next important one we should know is a block fluorescence. Where is block fluorescence seen? Block fluorescence is seen either because of a bleeding, okay, so blood or presence of either blood or RPE pigment which blocks the underlying retina is known as blocked fluorescence. Okay, the last one is capillary non-perfusion, which is non-filling of the capillaries. Non-filling of the capillaries. So with this introduction, we'll go to the slides. Okay, so you should know what is pooling, leakage, window defect, block fluorescence, and capillary non-perfusion area. So we should remember that we have the inner blood retinal barrier and the outer blood retinal barrier. The outer blood retinal barrier is formed between the zona occludens and the Bruch's membrane. Okay, the choriocapillaries and the Bruch membrane form the outer blood retinal barrier. The inner blood retinal barrier is formed by the choriocapillaries. Okay, so the intactness of the blood retinal barrier is tested in your fundus fluorescent angiography. So I told you the technique is through the antecubital vein. So what are the various phases? The first phase is the choroidal or the pre-arterial phase. Okay, so you can see that the choroidal vessels are filling up. Second is the arterial phase where the arteries are filling up. So remember, the arteries are narrower than the veins. The arteries to vein ratio, they may ask, the A is to V ratio is 2:3, or V is to A ratio is 3:2. So the veins are 3 times. The ratio of the vein is to artery is 3:2. Okay, the veins are more wider or broader than the arteries. Next is the arteriovenous phase or the capillary phase. After that, we have the venous phase. Starting is the mid-venous phase and later the late venous phase. The late venous phase, you can see that the complete venous filling occurs in the late venous phase. Last is the recirculation phase or the late phase. So what did I tell you? Pooling of the dye. Pooling of the dye occurs in open spaces. So first is PED. PED, what did I tell you? The pooling of the dye occurs in the sub-RPE. Okay, sub-RPE, the pooling of the dye occurs in PED. In case of PED. So one more important defect in PED, what happens to the fluorescence? The fluorescence will increase in intensity. Fluorescence will increase in intensity, but it will not increase in size. Not in size. So what happens in PED? The size remains constant, but the fluorescence will increase in intensity during the later phases. During the later phases, the fluorescence will increase in its intensity. Second is this CSR. What happens in CSR? CSR, because the fluid accumulation is in the sub-RPs, okay, subretinal space, the fluorescence increases both in intensity and size. So in CSR, the fluorescence increases in intensity and it increases in size. This is a very important differentiating points between CSR and PET. Okay. Another very important point is the appearance of the fluorescence in case of CSR. Okay. The CSR fluorescence is also known as ink blot. It's also known as pine tree fluorescence. Okay. Also known as smokestack fluorescence. So this will increase both in size and it will increase in intensity. During the later phases of FFA, it will increase both in the size and the intensity, whereas the PED, the fluorescence will increase in the intensity, but the size will remain constant. Okay, this is a very important differentiating factor. So you can see the pine tree appearance. This is the smokestack, typical smokestack. So this is the appearance of smoke coming out from the chimney. Okay, typical appearance of a smoke coming out from the chimney. This is known as the smokestack appearance. So this they have asked in one of the AIMS papers. So remember, smokestack, pine tree, and ink blot appearance is an important finding in FFA of a CSR patient. So what did I tell you? Window defect is because of the RPE atrophy. The RPE atrophy may either because of an age-related degeneration or because of angioid streaks, or it could be because of dry ARMD. Also a full thickness macular hole and can result in RPE atrophy. So another important defect is the Stargardt's disease. Stargardt's disease, the patient will have a silent choroid along with RPE atrophy. Okay, silent choroid along with RPE atrophy. So this is the angioid streaks. Angioid streaks is the break in the Brooks membrane. So the break in the Brooks membrane is known as angioid streaks. These patients typically present with a CNVM. Okay, these patients typically the vision loss in the angioid streak is because of CNVM. The mnemonic for angioid streak is Pepsi. Okay, Pepsi pseudoxanthoma elasticum, Ehlers-Danlos, Paget's disease, and sickle cell anemia. Okay, Pepsi is the mnemonic for your angioid streaks. So next is the full thickness macular hole. So you can see that the full thickness macular hole also there is a window defect. Okay, because of the hyperfluorescence in the defect. This is the bullseye maculopathy. Bullseye maculopathy is because of chloroquine toxicity. Because of excessive chloroquine toxicity, this results in bullseye maculopathy. Yeah, this is the filling defect. So what happens here? So you can see that the superior part, the blood supply is completely absent. So this is a branch retinal artery occlusion. So you can see the pale retina superiorly, and also the FFA confirms the location of the blockage. So this is a CRAO with a cilioretinal artery sparing. So you can see that the macula is still spared in this patient. This occurs in about 25% of the patients with CRAO. So the macula will be spared in these patients because of the involvement of because of the cilioretinal artery sparing. Okay, this is the CRAO with cilioretinal artery sparing in patients with CRAO. Okay, about 25% of the patients. Okay, so this table will it will summarize what all we discussed just now: the window defect, the leakage, the pooling, and the staining. Okay, so we should be able to differentiate between the changes which occur in CSR and PED. That is very important. So ICG, a few points. ICG, remember, the disc does not stain in ICG. How do you differentiate the ICG from FFA? The disc will not stain in ICG, but the FFA picture, the disc will be staining. Second important thing is ICG is investigation of choice for any choroidal pathology, mainly any choroidal pathology, mainly your occult CNVM, your polypoidal choroidal vasculopathy, okay, your choroidal polyps, small choroidal polyps, all these, the investigation of choice is ICG. So in any choroidal pathology, the investigation of choice is ICG. How will you differentiate from FFA? There is no staining of the disc on ICG. Okay, ICG, there is no staining of the disc. This is a very important point to remember. Okay, now a few points about diabetic retinopathy. Quickly, we'll go about the diabetic retinopathy. So remember, the changes which occur in the lens are due to the sorbitol accumulation. Okay, the sorbitol accumulation in the lens results in the diabetic cataract. We know that the diabetic cataract is a snowflake cataract. The changes which occur in the retina are because of the advanced glycation end products. Okay, so the accumulation of the advanced glycation end products is responsible for the various retinal changes occurring in diabetic retinopathy. Okay, in diabetic retinopathy, we should know the level of lesion and how does it present. Okay, first is the microaneurysm. So remember, the microaneurysm is the first lesion to appear in diabetes retinopathy. The first lesion to appear is the microaneurysm. So which level is the microaneurysm present? It is present in the inner nuclear layer. Inner nuclear layer. Okay. The second is the superficial flame-shaped hemorrhages. Superficial flame-shaped hemorrhages. See, these flame-shaped hemorrhages are present in the flame-shaped hemorrhages are present in the nerve fiber layer. Okay, the deep hemorrhages are also known as the dot and blot hemorrhages. Dot and blot hemorrhages. The dot and blot hemorrhages are deep hemorrhages which are present in the inner nerve fiber layer. Inner nerve fiber layer. So remember, the inner nuclear layer, microaneurysm, and the deep dot and blot hemorrhages. The nerve fiber layer is the superficial flame-shaped hemorrhages. The last we have the cottonwool spots. So what are cottonwool spots? Cottonwool spots are the infarcts seen in the nerve fiber layer. The infarct seen in the nerve fiber layer is the cottonwool spots. And last is the hard exudates. Hard exudates is the cholesterol deposition in the outer plexiform layer. The outer plexiform layer is also known as the layer of Henle. Okay, this we discussed in the class. So if you remember, the hard exudate accumulate in the outer plexiform layer of Henle. Okay, so these are the important lesions of diabetic retinopathy. So quickly we'll go through the question. So this is the vascular front. So this is suggestive of a presence of a vascular front, is suggestive of a new blood vessel. Okay, this is, if it is one disc diameter close to the disc, it is known as NVD. If it is away, more than one disc diameter away from the disc, it is known as neovascularization elsewhere. So presence of neovascularization indicates the presence of a proliferative diabetic retinopathy. So presence of a new blood vessel suggestive of a proliferative diabetic retinopathy. So I told you the changes which occur are due to the advanced glycation end product. So there is loss of capillary pericytes. Okay, and yeah, so one more important thing you should know about the newer drug called lampalizumab. Okay, lampalizumab is the monoclonal antibody which is which inhibits the complement factor D. Okay, so it's still in the phase 2 trial. It's still not got any approval, but you may get a question on this. Okay, lampalizumab. One of the aims question they have asked about lampalizumab. Okay, INI-CET questions. Okay, so this is the ARMD. This is the dry ARMD, and this is the wet ARMD. Wet ARMD we call it when there is a presence of a new blood vessel. Okay, when there is a this is wet ARMD we call it when there is a CNVM or capillary neovascularization membrane. Okay, capillary neovascular membrane is known as a wet ARMD. Okay, so this we can see this is a CSR. There's a small PD associated. So typically you have the pine tree appearance or the ink plot appearance, which increases both in the intensity and size. So this is a CSR. Okay, this is a CSR. Next, we have hard exudates present within one disc diameter of the macula. The typical appearance on the FFA is the classical patelloid appearance. Patelloid appearance on the FFA. So this is the presence of fluid accumulation in the outer plexiform layer. There is a fluid accumulation in the outer plexiform layer. So this is known as the cystoid clinically significant macular edema. Okay, this is typically a feature of diabetic maculopathy. So we'll go to questions quickly. Okay, so this we got in the last NEET 2021, the recent NEET. So a patient, elderly female with a progressive diminution of vision. So this is the fundus finding. So what did I tell you? There is presence of hard exudates within one disc diameter. So this is a hard exudates in diabetic maculopathy. Okay, so what is the according to the ETDRS classification, it is called as clinically significant macular edema when there is a retinal thickening within 500 microns from the fovea, the presence of hard exudates within 500 microns of the fovea associated with retinal thickening, or retinal thickening within one disc of the fovea associated with hard exudates. So this is the classification based on the ETDRS. This slide, if you can take a screenshot, it has all the details. Okay, so this we have a patient who's a 73-year-old female who's a well-controlled diabetic who underwent a uncomplicated phacoemulsification. So now what we have a flower petalloid appearance. So what is this? This is a cystoid macular edema. Okay, this is a cystoid macular edema. Post cataract surgery, cystoid macular edema is also known as the Irving gas syndrome. So which is the level of the lesion? The level of lesion here is the outer plexiform layer. Okay, the level of lesion here is the outer plexiform layer. Okay, so next, all the following are acceptable treatments for this patient except. Okay, so remember, these patients typically we follow up the patients. We do not do laser at the first sitting. We give the patients topical steroids. We give the patient topical NSAIDs in combination with topical steroids. follow up the patients. If it does not resolve within the 3 or 4 months, then we go ahead with the focal grid laser. So focal grid laser is not done in Irving-Gass syndrome, okay, or post cataract cystoid macular edema. So okay, here also we have a 60-year-old woman with diabetes and hypertension having difficulty in reading since the past 4 months. Her visual acuity is 20/25. Her fundus photograph and FFA is given below. So according to the ETDRS, which of the following is considered clinically significant macular edema? So I told you, when the retinal thickening is greater than 1 disc diameter in size and it lies within 1 disc diameter of the center of the fovea, it is known as clinically significant macular edema according to the ETDRS classification. So these are the 3 points: retinal thickening within 500 microns, hard exudates within 500 microns with retinal thickening, and retinal thickening of 1 disc diameter or greater, part of which lies within the 1 disc diameter of the fovea. So this is the classification based on the ETDRS, which stands for Early Treatment of Diabetic Retinopathy Study. So all the following would be accepted as management for this patient except, okay, so remember, this patient, we do not do PRP. We do not do PRP. For macular edema, we do a focal grid laser. We do not do a pan-retinal photocoagulation. Pan-retinal photocoagulation is done for new blood vessels which are present in the periphery. Okay, so it is the laser which is given in the periphery. For the macula, we have to give a focal grid laser. Okay, so this is the last question. Okay, so we have a 54-year-old poorly controlled diabetic with floaters in the left eye. See, best vision is 20/20 in the right eye and 20/80 in the left eye. So this is your FFA and the fundus photo. So according to diabetic retinopathy study, all the following meet the high risk criteria for classifying as proliferative diabetic retinopathy except. So which does not meet. So the answer is A. Okay, the answer is 1 disc diameter of isolated neovascularization elsewhere does not meet the DRS classification. Okay, so with this we will finish the class. Okay, so we will continue class on Monday. Hopefully this is useful. Okay.
Hello? 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 Are you able to hear me? Hello? Are you able to hear me? Okay, so I welcome all of you for today's special topic, an expected question for an upcoming NEET November 2021, or it could be NEET or next 2022. The question reads, a patient presented with vomiting and features of gastric outlet obstruction. He has an infiltrating cancer from the stomach to the pancreas into the duodenum and having multiple liver metastasis in the right lobe of the liver. What is the ideal treatment for him? See, this question is a CA stomach with a metastatic disease. The option A, what is the answer? What will you do for him? What's the treatment, ideal treatment for him? Palliative gastrojejunostomy, right hepatectomy with radical gastrectomy, Whipple's procedure, and palliative care. See, the right answer is only palliation. And what kind of palliation you need to do is the discussion here. The right answer is option A. Next, it is palliative gastrojejunostomy. Understand this. For CA stomach, the best form of palliation is a surgical palliation. In case the patient is fit and in case he can be amenable for a surgery, then definitely you will do a posterior gastrojejunostomy for a benign disease. But for a CA stomach, for a malignant disease like this, you will try to do a anterior gastrojejunostomy for the reason that all the cancers have a tendency, especially the gastric cancer, have a tendency to grow posteriorly, infiltration, the posterior wall of the stomach, and it goes posterior into the stomach bed. There is a gastric bed of the lesser sac, and it infiltrates to the underlying structures like pancreas, as given in this question, and the duodenum, so that this infiltrating cancer stomach involving the pancreas and the duodenum. So if you do a posterior gastrojejunostomy, as in case of a peptic ulcer disease presenting with a gastric outlet obstruction, here if you do that, there'll be an early obstruction will happen, so that you will always try to do a anterior gastrojejunostomy. Understand that, anterior gastrojejunostomy, palliative anterior GJ, anterior gastrojejunostomy. Now, what are the other form of palliation? If the patient is not fit enough, you will try to do stenting. You can do a stenting across the tumor. You can dilate the tumor. You can stent it across. But the stenting for gastric cancer does not yield a result that stenting for esophageal cancer gives. The chances of the stent getting obstructed by the food bolus or the chances of the stent getting migrated and displaced are very, very common than esophageal stenting. So if the patient is fit enough, the best will be to do a anterior gastrojejunostomy. The right hepatectomy with radical gastrectomy is not an option here. Whipple's procedure definitely not an option here. Whipple's procedure is the pancreatic duodenectomy. Is an ideal procedure done for CA head of pancreas or periampullary carcinoma of the duodenum, and it can also be a part of a treatment protocol in case grade 5 pancreatic head injury. So the best option available here, the best will be palliative gastrojejunostomy. Understood? Now, I want to tell you, you need to understand this very, very clearly, that what are the external markers of inoperability of CA stomach? Yes, inoperability, here it means incurable, not a curative resection, correct? Where you will not do a curative resection of CA stomach. Number one, we'll go from head to foot. Number one will be jaundice. That means it tells you hepatic metastasis. Number two will be virtuous lymph node. Enlargement of left supraclavicular lymph node. It is called virtuous lymph node. And it is a sign of curative resection and contraindication to do a curative resection and a sign of inoperability for a curative resection. Then will be lymph node of iris. Lymph node of iris is located usually in the axilla. An iris lymph node is a metastatic lymph node of a CA stomach. And that could be a cause and that could be a reason of inoperability or a curative resection in CA stomach. Then it could be Sister Mary Joseph nodule. These are the periumbilical metastatic nodules. In a case of a CA stomach, the malignant cells follow the lymphatics of the falciform ligament to reach the umbilicus and presence is a periumbilical nodule. Clear? So that is a sign of inoperability, Sister Mary Joseph nodule. Then peritoneal involvement and peritoneal metastasis can lead to malignant ascites. And malignant ascites is a sign of inoperability and not for a curative resection. And then it could be a Krukenberg tumor. It's a transcoelomic spread of CA stomach into the ovary, into the active ovarian follicles. To produce as an ovarian tumor is called Krukenberg tumor, is a sign of inoperability. And the metastasis into the Bloomer shelf, the metastasis, CA stomach, getting a patient will have a distant lymph node, distant, especially N3 and N4 lymph node is a sign of inoperability. You understand what I say? So these are the signs of inoperability means that this cancer is not a curable cancer by surgery. In case you do a surgery, if the patient is fit enough, you can do a palliative surgery like an anterior gastrojejunostomy. And this are the signs. I'll just repeat it once again for you for the benefit of all. So it could be the icterus, that is, jaundice, number 1. Number 2, it could be the virtuous lymph node. Yes. Number 3 will be iris lymph node, a metastatic lymph node in the axilla, most commonly on the left axilla. Number 4, Sister Mary Joseph nodule. Number 5, ascites. Number 6, Krukenberg tumor. Number 7, Bloomer shelf metastasis. Number 8 could be distant lymph node metastasis. Number 9, any distant organ metastasis in the CA stomach is a sign of inoperability and is a contraindication for curative resection. Understood? Is it very clear? Excellent. Now go to the next slide. Now, where is the substantiating point? The 21st edition of Subiston is the latest edition of Subiston. And because, see, as an undergraduate during a final year, to you to read Bailey itself is a very big deal, and to read on to Subiston textbook and to read on to Schwartz textbook of surgery of 11th edition will be a big task, but the questions are asked from these books. So it is the responsibility of teachers and faculties like me to read those points and get on to you the crisp of the gist of what is given there so that you'll be able to answer it in the exam very easily with the reference. Next slide. So it is very, very clearly given in page number 12, 13, 21st edition of Subiston latest edition. It came 6 months before. Now it very clearly explains the patient with unresectable or metastatic gastric cancer account for almost 50% of patients presenting with the disease have only 3 to 5 months of median survival with the best supportive therapy. While many patients with advanced disease are asymptomatic, a significant subset of patients with an unresectable gastric cancer have debilitated symptoms and should be considered for palliative surgical therapy, even in the setting of metastatic disease. So metastasis is not a contraindication to a palliative surgery. Be contraindication for a curative surgery, but not for a contraindication for a palliative surgery. The most common procedure in the setting is gastrojejunostomy. I said it is an anterior gastrojejunostomy. However, a palliative gastrectomy can be considered in a select patients. Understood? So it is very, very clearly said. And go back to the question. And this is the topic for us to discuss today. CA stomach, one of the most common cancer in GIT. Yes, in GIT, they'll ask you the other questions here. It is the most common location of lymphoma in GI. The most common location of lymphoma in GI is stomach. They'll also ask you the most common location of leiomyoma in GIT. Again, it is stomach. So anything they ask you in GIT, the most common site is one of the most common site is stomach. So you need to understand that. Okay. So CA stomach is a very, very, very important topic in exam, and management of CA stomach is also very important topic in exam. So we will be discussing all this in detail in the classes, and this is expected question for the upcoming INICET and the upcoming NEET exam. So an elaborate class will discuss end-to-end and everything on all these topics. So I request all of you to come to speed, join speed, and also you will learn a lot, and definitely you will enjoy learning, and you will definitely have a difference in learning, and you will love it. And speed learning app is such a wonderful tool, and it will give you live classes and very good classes by the faculties. And I once again welcome you to join the speed learning app done by Speed Institute. Thank you very much and have a wonderful day. Thank you.
Hello, am I audible? Okay, so let's start. So today will be the last session of the obstetric ultrasound, and today we'll be focusing on the third trimester ultrasound in obstetrics. So the main things that we'll be seeing in third trimester, very important, is the growth, because at this stage you want to know if the baby is small or big. And more importance to it being small, because it will, in which case it will be called intrauterine growth restriction. And there is a high chance that these small babies can lead to stillbirth. And that is something that you definitely want to avoid. So you have to monitor and find out, diagnose if the baby is growing properly. So the growth part is the most important parameter that you want to monitor in the third trimester. And adjuvant to it, you'll want to look at the Leica and Doppler as well to see how bad the IUGR is. Again, you will look at the placenta again. If you have diagnosed placenta previa or low-lying placenta in the second trimester, you want to reconfirm at around 36 weeks to see if it is still low-lying or placenta previa. Because after this point, there is very less chance that the placenta will move up, and you will have to plan for a cesarean delivery if the patient persists to have placenta previa. So let's start. How do you calculate the growth of the baby? So you need to look at all of these four parameters. You have to measure the biparietal diameter and head circumference of the baby's head, abdominal circumference around the abdomen of the baby, and femur length of the leg. Once you measure this in the ultrasound machine, the machine itself will give you a calculated estimated fetal weight of the baby. And based on that, and based on the gestational age of the patient, you have to plot it on a growth curve. This will be dealing in IUGR on a growth curve, and if it is less than the 10th centile for that gestational age, you will call it as IUGR. And if it is more than the 90th centile, it is called as large for gestational age or macrosomia. Okay. So the first thing is the head, biparietal diameter and head circumference in the head. So imagine this is the baby's face. Okay. So this is the cross section, transverse section, and you're viewing at the image from the top. So let's look at the structure. So this is a cross section, the transverse cross section of the baby's head. And you have to make sure that it is taken at the level of thalamus. So these two black structure or the thalamus. Okay, this is a simple diagram on this side. So this corresponds to this part. And the straight line, can you see a straight white line in the center? That is the falx cerebri here in the line diagram. And these two small white lines is the cavum septum pellucidum. So when you are taking a transverse section of the baby's head, you have to make sure that the biparietal diameter and head circumference is measured at this particular plane, where you can visualize the thalamus, the falx cerebri, and the cavum septum pellucidum. Biparietal diameter is measured from the outer table of the fetal skull on one side, perpendicularly straight line to the inner table of the other side's fetal skull. Okay, so outer to inner, not outer to outer, not inner to inner, it is outer to inner. Head circumference is in the same plane. You measure the circumference of the head. The yellow line, the circular line, is how you measure the head circumference. The next one is the abdominal circumference. Again, this is a cross section. It is a transverse plane. And here you have to make sure, again, so this yellow line is how you measure the abdominal circumference. And at which plane do you take this cross section? You have to visualize the stomach, the spine, two ribs equally on each side, and the U-shaped vessel, which is the umbilical vein. So let's see here. This black structure is the stomach. Can you see a white color structure here? with some irregular projections. That is the spinal cord. And you have white structure here and white structure here. That will be the rib. And this black color tiny worm-like structure is the umbilical vein. So at the level of the stomach bubble, umbilical vein, spinal cord, and 2 ribs on each side. This is where you measure the abdominal circumference, and it should be circular. It should not be oval or any other, pressed Okay, so let's continue. So the next measurement will be the fetal length in the baby's leg. So this is the femur bone in the baby's leg, and you have to measure only the diaphysis. Don't include the epiphysis. These two small dots in the fetus, if you remember, the epiphysis and diaphysis will join only at a later stage. So when you're measuring, you internal os, this is the external os, which is not opened again. Now, if placenta is seen below the fetal head. Doppler is nothing but a wave-like representation and a pictorial representation of the blood flow in any vessel. Okay, so imagine this is a blood vessel, and the blood flow is flowing this way in one direction. And when you keep the probe on the patient's abdomen, first a frequency of wave is directed against the blood vessel, and from each RBC, the wave will be reflected back to the ultrasound. And this will be interpreted like this on the machine. For example, this is umbilical cord. Umbilical cord, you're measuring the flow of blood flow along the umbilical artery. Okay, so by this principle, it will be represented like these mountain-like structure. That is nothing but the blood is flowing inside the umbilical artery. So what are the vessels that are studied in the fetus? First will be the umbilical artery, middle cerebral artery in the baby's brain, and the ductus venosus in the deficiency. If the baby is not getting enough blood through the mother's blood flow to the placenta, all the Doppler through these vessels will be affected, and that is how you know how severe the IUG are and if you want to deliver the baby early. So let's look at some pictorial waveforms. Usually umbilical artery will be like this, peaks of mountain like this. Okay, so if you can see, there's a peak and there's a trough. The peak is the blood flow during the baby's systole, and the trough is the blood flow during baby's diastole in the umbilical artery. So if you notice, there is blood flow during both systole and diastole of the cardiac cycle in the baby's body. Okay, so as the IUGR worsens, you can see that the diastolic blood flow starts decreasing. And at one point, there is only systolic flow. There is no flow during the diastole. And if it is really severe IUGR, there will be reversal of flow during the diastole. This is the most severe form. Let's see how this is seen in the ultrasound. Okay, so this will be the systole peak, and this is the diastole, the trough. This is a normal umbilical artery waveform. Diastolic flow. Whereas here you can clearly see that it is coming below the line. So this is reversal of diastolic flow. And this is the most severe form. You will have to deliver the baby immediately. Okay, so middle cerebral artery measurement in the baby's brain. So this is the circle of Willis, and this is the middle cerebral artery that is going in IUGR babies. Which is called as the brain sparing effect. Because of this, there will be am I audible now? Can you hear? Okay. So because of this, there will actually be increased blood flow during the diastole if there is IUGR and brain sparing effect. Okay, if you can compare these two, can you see the blood flow during diastole here and here? Obviously, the amount of blood flow is more here, right? So it is the opposite of umbilical artery. If there is IUGR and if the blood flow is compromised, the baby will shunt more blood towards its brain, and this is called brain sparing effect, and the amount of blood shunted during diastole will be more. So this is how the wave pattern changes. All right. The last will be ductus venosus. In ductus venosus waveform, the structure is little different. Can you see the previous ones were like mountains, whereas here you can see a wave like that and a dip. Two peaks and a dip. Two peaks and a dip. This is how a normal ductus venosus waveform looks like. So there is systole, diastolic flow, and A wave, S wave, D wave, and A wave in ductus venosus. And it is measured in the ductus venosus vessel in the baby's abdomen. So this is the normal waveform. S wave, D wave, and the trough is called the A wave. Whereas when it starts becoming abnormal, slowly the A wave will start disappearing, and in a very severe state, the A wave will be reversed like this. All right. A small note on the obstetric MRI, because this is something of importance nowadays. Two main uses of obstetric MRI is to detect placenta accreta spectrum, that is placenta accreta, increta, and percreta. And also, if you're suspecting fetal neural anomalies, obstetric MRI will be a good investigation to see what kind of anomaly. Now, this is an MRI picture of a sagittal view wall. The whole thing is the uterus, and if you can see, this is the baby's brain, and this is the baby's eyeball. Can you see? This will be the cervix. So if you can see again, there is a big mass-like structure between the baby's head and the cervical canal, and this will be the placenta. Okay. MRI is especially useful to detect posterior in case of placenta accreta syndrome, and you can also find out if it is extending into the nearby organs like the bladder or the bowel to plan for your surgery. So these are some of the features in the MRI that you have to look out for in placenta accreta syndrome. Dark T2 bands, there will be uterine bulge, heterogeneous texture. It will not be a plain gray color structure. There will be gray and white. Okay, disorganized vasculature when you switch on the Doppler, and the uteroplacental plane is not smooth. It will be disrupted. All right. So, and last point today will be to see there are different radiological investigations that you can provide to a pregnant patient, but radiations can be not safe for the fetus. So we should know what is the limit up to which any radiological exposure is safe in the mother as well as the baby. For any gestational age, the rule is up to 5 rats it is safe. More than 16 weeks, even up to 50 rats is safe. So if you look at the common investigations that we do, can you see chest X-ray is actually CT lumbar spine, but even that is less than 5. So with maternal shielding, if you think it is absolutely necessary for the mother, you can still go ahead and offer this. The highest will be for barium enema, but this is something that is not usually done in pregnancy if it can be waited till the delivery is over. All right. So this ends today's session on imaging in 3rd trimester. Hope that was useful. Thank you very much.
A very good evening to all. So today we'll be discussing one more interesting topic in pediatrics, that is neonatal polycythemia. So everyone is aware of the definition of polycythemia. Polycythemia is nothing but hemoglobin which is high in content and which is having potential of causing symptoms pertaining to hyperviscosity. So the polycythemia which you are aware of in adults or in infant or in children is slightly different from the polycythemia which you are worried about in neonates, because in polycythemia in neonates can in itself be a problem and might complicate the recovery of the baby in a neonatal intensive care unit because of various reasons. So in today's class, we'll be discussing the topic of polycythemia. We'll be going first through the MCQs, which will ask you about what is the correct definition of polycythemia in an infant, how do you define it, and what is the correlation between hemoglobin as well as PCV or packed cell volume or the hematocrit. What are the clinical manifestations, or what is the clinical presentations when you start suspecting polycythemia as the etiology for the symptoms in your baby. What is the situations where you start doing neonatal screening for polycythemia? What is the etiology of polycythemia? And of course, we'll be trying to look out for clinical manifestations and management. So all will be covered today in a briefest possible way, yet in the most effective way in an MCQ fashion. So this is the first question for the day on the polycythemia. Diagnosis of polycythemia is made in the presence of a venous hematocrit value of more than how much? So the correct answer for this is 65%. Now in general, they say that a value of 65% or more is called as polycythemia. Polycythemia. Now remember, polycythemia in general, the definition is 65%, but there are two terminologies. One is asymptomatic polycythemia, other one is symptomatic polycythemia. Now the definition of symptomatic and asymptomatic polycythemia is made slightly different, because if you have an asymptomatic patient with a PCV or a hematocrit value of more than 75%, I will consider treatment of this person. If it is more than 65% in a symptomatic patient, I would consider again treatment of polycythemia by doing phlebotomy or volume exchange. But if the patient is having asymptomatic polycythemia with a packed cell volume of 65 to 75%, here I can just wait for plasma exchange or or just hydrate the patient and see whether he improves or not. So though the definition of polycythemia is more than 65%, there are different cutoffs for the management. The definition of polycythemia in a neonate is a PCV of more than or equal to 65%, and when it comes to the management, any patient with symptomatic polycythemia will require the treatment in the form of partial exchange transfusion. If the patient is asymptomatic and still if you want to treat the patient by partial exchange transfusion, then the packed cell volume or the hematocrit value should be more than 75%. In asymptomatic patients where the hematocrit value is between 65 to 75, then in such situations you can consider hydration or monitor for the symptoms depending upon the patient's clinical condition. So this is in brief regarding the diagnosis of definition of polycythemia. Again, to reiterate the fact, the Flaherty and Stark's Manual of Neonatal Care defines polycythemia as a venous hematocrit value of more than 65%, or in terms of hemoglobin, you can consider it as a concentration of more than 22 gram per deciliter of hemoglobin that is constituting neonatal polycythemia. So now you also know that hemoglobin values, normal values are different for different age group, including the effect of prematurity. So in terms of standard deviation, if the hemoglobin is more than 2 standard deviations above the mean, then also we will consider the diagnosis of neonatal polycythemia. Now they'll ask you, if the hemoglobin is 22, what is the likely hematocrit value? So that is one sort of question. Or if the hematocrit value is 65%, what is the value of hemoglobin? So let us assume that if hematocrit is 65%, as in this case, now if I divide it by 3, I get a rough value of hemoglobin as 22. That means PCV or packed cell volume, also called as hematocrit, can be derived from the formula three times the hemoglobin value of the baby. So if you use this formula, you can derive hematocrit or PCV from the baseline hemoglobin concentration. So the relationship between hemoglobin and hematocrit or PCV is 3 times the hemoglobin. Now, at the same time, you should also know that the prevalence of polycythemia is to the tune of up to 15% for term small for gestational age baby. Now, this is very important. This is very low when compared to that of 2% at that of term babies. So, preterm premature babies are at risk of developing neonatal polycythemia because of various reasons. But in term babies, if at all you want to suspect risk of polycythemia, then better they be small for gestational age. Small for gestational age. So this is about neonatal polycythemia. With this, we go to the clinical presentation of a baby who is a term male infant, that is a male baby who was born at term, but the weight is 2.2 kilograms. So that means it's small for gestational age and a male baby. So we have clues like male baby and small for gestational age. Now, this 2.2 kilogram baby with uneventful antepartum and intrapartum period has presented with lethargy and apnea at 2 hours of birth. On examination, it reveals normal vitals with plethoric appearance with acrocyanosis, poor pulses, and a systolic murmur in tricuspid area. So the clues which are given are: he is a male baby, he has small for gestational age, and the features of lethargy, apnea. Now, lethargy and apnea can happen both with hypoglycemia, hypocalcemia, in addition to polycythemia also. Disseminatory intravascular coagulation will present with either bleed or thrombosis, so this is less likely of the diagnosis. But how to differentiate A, B, and C? We do not have glucose value, we do not have calcium values, and we do not have hemoglobin values. At this point of time, you should see for the other clues in the in the question. So plethoric appearance. Plethoric appearance means congested face. Congested face. Acrocyanosis. This congested face and acrocyanosis are very much common in patients with polycythemia. The other clue for the polycythemia is persistent pulmonary hypertension in this neonate, which has resulted in systolic murmur. So the presence of polycythemia delays the fall in the PA pressures in the baby, which happens immediately after birth. Then this results in a situation where the patient is having pulmonary hypertension, tricuspid regurgitation, and this tricuspid regurgitation will result in systolic murmur in the tricuspid area. So this is the another clue for this baby having polycythemia. Now this is how the clinical presentation of polycythemia is. Now we move on to the next question. What is the etiology of polycythemia? So in the previous slide, you have just seen that there was one etiology which was small for gestational age baby. But here you see that now not only that, there are multiple other causes of polycythemia. Take it: placental insufficiency, post-maturity, toxemia of pregnancy, drugs, severe maternal heart disease, maternal smoking, and infant of diabetic mother, neonatal thyroid issues, congenital adrenal hyperplasia, all the trisomies which you ever have heard of, Beckwith-Wiedemann syndrome. All these are causes of increased erythropoiesis which has resulted in polycythemia. Sometimes there may be polycythemia because of secondary causes, like if you delay the cord clamping, the amount of blood transfused from the mother to the baby is going to be more, and there will be polycythemia. Maternal to fetal transfusion and twin to twin transfusion, these issues which are going to happen in twin pregnancies can also be a cause or etiology of polycythemia. So this is in brief regarding etiology of polycythemia. Now we go to the clinical manifestations of the baby with polycythemia. All of the following can be manifestations of polycythemia except options are jaundice, thrombocytosis, hypoglycemia, hypocalcemia. Now, though hypoglycemia, hypocalcemia both can mimic polycythemia, you should understand that both hypocalcemia and hypoglycemia can be precipitated by polycythemia as well when you see the clinical manifestation and the pathophysiology of polycythemia. Now, when polycythemia is there is increased red blood cell count. When there is increased red blood cell count, there is increased risk of hemolysis, and hemolysis will release bilirubin. So by default, I can say that hypocalcemia, hypoglycemia, and hyperbilirubinemia, that is jaundice, can be a part of polycythemia. But what is not the part of polycythemia? The one which is not the part of polycythemia is because of the hyperviscosity, there is activation of the intravascular coagulation cascade that results in consumption of the platelets. Thereby, this patient will have thrombocytopenia rather than thrombocytosis. So, answer for this question becomes B. So, if you look into the manifestations of patients with polycythemia, the pathophysiology mainly evolves around the hyperviscosity which is caused by polycythemia. Hyperviscosity results in a situation where the cell will eat up more of glucose and calcium, thereby resulting in hypoglycemia and hypocalcemia. Increased red blood cell turnover results in hyperbilirubinemia. And this hyperviscosity, whenever it is flowing through a narrow capillaries, this results in sluggishness of the microcirculation, where the gastrointestinal tract will be congested, resulting in necrotizing enterocolitis. The renals will be affected, resulting in renal vein thrombosis and acute renal failure. The central nervous system is affected, resulting in irritability, seizures, jitteriness, and cerebrovascular accidents. The cardiovascular system is affected, resulting in tachycardia, cardiac failure, and tachypnea. And coagulation is affected, resulting in thrombocytopenia and DIC. Now, the next question is whom to screen in order to identify the neonates who are at risk to be looked for and managed accordingly. So the options are the small for gestation age, infants of diabetic mother, infants with trisomy 13 or 18, and extreme preterm. The question is which of them will not require screening? Which of them will not require screening? Now, the answer for this question seems to be D. The reason is a small for gestational age, as you have seen in a case scenario, is well known to have been associated with polycythemia. And in the etiology of polycythemia, we have also seen that infant of diabetic mothers are well known to be having at risk of polycythemia. Trisomy 13 or 18 also will have a risk of polycythemia. So what is the extreme preterm at risk of? The extreme preterm is at risk of anemia of prematurity rather than polycythemia. So this is the reason why the answer for this question is option D. The answer for this question is option D. So this is about routine screening. So in general, the routine screening for neonatal polycythemia is done in those patients who are having symptomatic hypoglycemia, hyperbilirubinemia, and thrombocytopenia, either small for age or large for gestation age. Post-term infants are going to have a high risk of polycythemia when compared to that of extreme preterms. Intrauterine growth retardation again will have been associated with polycythemia. Infants of diabetic mothers, monochorionic twins, and infants with chromosomal abnormalities. All of them will be at risk of having polycythemia. So the last thing to be discussed in the topic of polycythemia is the management of polycythemia. So what is the management of polycythemia? So the management of polycythemia is pretty simple. The first thing which you have to look for whenever you are suspecting polycythemia is confirm the diagnosis by doing a hematocrit or PCV value. If the hematocrit or PCV value is 65% or more, the diagnosis of polycythemia is considered. You need to exclude dehydration and check for weight loss, which will rule out hemoconcentration as a cause of polycythemia. That will be a pseudo cause, pseudo polycythemia. Now, once you have ruled out hemoconcentration, the next thing is to see whether the patient is symptomatic or asymptomatic. If the patient is symptomatic, partial exchange transfusion is the key. If the patient is asymptomatic and is having a hematocrit value of 75% or more, the partial exchange transfusion is still on. But if the patient is having a hematocrit value of less than 75%, then the management is going to slightly differ. If the patient is having 65 to 69% hematocrit value and the patient is asymptomatic, just monitor for symptoms and keep quiet. If the patient does not develop symptoms, ensure adequate breastfeeding, everything will be fine. If the patient is having polycythemia in the absence of symptoms but is on the higher side, that is 70 to 74%, now here you can start considering fluid relaxation or giving IV fluids to the baby. So this is in brief regarding management of polycythemia. So the volume what you have to exchange is calculated by the formula blood volume into the observed hematocrit value minus desired hematocrit value divided by observed hematocrit value. So what is the observed hematocrit value? It is usually 65% in case of symptomatic polycythemia and 75% in case of asymptomatic polycythemia. What is the desired desired value? That desired value is around 45. That is 15 into 3. If the hemoglobin of a neonate is considered to be 15 to 18, then PCV of 45 is the desired value. So the blood volume 80 ml per kg for a 75 ml per kg for a term neonate into observed value would be 65 and desired value would be 45 divided by 65. So this will be the volume of the blood that has to be exchanged in order to get back this patient from symptomatic polycythemia into a normal range. So this is in brief regarding the management of polycythemia. So here we complete the topic of polycythemia. I hope we have understood the topic of polycythemia. We have discussed the various aspects of polycythemia right away from the definition of polycythemia, the etiology of polycythemia, the clinical presentation of polycythemia, where we have to routinely screen the patients for neonatal polycythemia, and what are the manifestations of polycythemia, and also we have touched upon how to manage a case of polycythemia. So this is it, and see you next time with a new topic with a new MC. Thank you all.
Okay. So welcome back to the expected question INICET session. We'll be discussing anesthesia questions from this particular slot. So in this discussion, I want to discuss a very common question, very famous question, and a question which was asked in the recently concluded NEET PG 21 exam. This is an image-based question from airway management. It is very, very important. At the same time, very easy. Okay. So let me take you to the question first, and then we'll discuss certain important aspects of your airway management methods. Okay. So this is a question. Again, this is a NEET PG 2021 question, but it has got equal importance in INICET exam as well. The image below done for airway management include. So one particular image is given, and the options are head tilt, chin lift, B, inline manual stabilization, C, jaw thrust, and D, head extension. So what is the procedure that has been given here? What is the image that is given here? You can see that one hand here, you can see that one hand is causing extension of the head or head tilt, and the other hand is causing a chin lift. So this is a simple straightforward question. Your answer would be head tilt, chin lift. Okay. So there are certain important procedures which are mentioned here, or techniques which are mentioned here. I'll explain one by one, and you will have to have a thorough observation of all these images, because airway management is one of the most important aspects of anesthesia. So definitely an image-based question can come from this session, right? So as I told you, this particular maneuver that you are seeing here is what is called as head tilt, chin lift maneuver, right? So what is happening is it might either be performed by a single person, or it might also be performed by a two-person. If a single person is performing this procedure, you can see that one hand will be used, one hand will be held over the forehand, and that will be causing neck extension. And along with that, the other hand will be causing chin lift. Now, what is the purpose of causing head tilt, chin lift? What is the science behind this procedure? The science behind this procedure is very, very simple. Now imagine you are having a patient who has had a collapse, who is just collapsing, and the patient is having a low GCS. So in that particular patient, your airway might also be obstructed. So you might have an obstructed airway. You might have something which is called as an obstructed airway. And how do you think the airway can get obstructed if a patient is having low body tone, as which can happen in a collapsed airway? The most important problem is your tongue is going to fall backwards. It is going to obstruct the pathway of your airway. The tongue is going to fall backwards, and it is going to obstruct the pathway of your airway. Similarly, one more important issue that you might have is the epiglottis might also flow over the glottis, causing airway obstruction. So when you are talking about obstructed airway in a patient who is collapsing, it can happen as a result of tongue going backwards. It is called as tongue fall. When tongue is going backwards, it is called as tongue fall. It might also happen as a result of your epiglottis closing over your glottic opening. Epiglottis closing over your glottic opening. So these are the two reasons why you might have an obstructed airway in a patient who is collapsing. Now, what will this head tilt chin lift maneuver do? When you are causing this head tilt chin lift, if you can see clearly, actually what you are causing is you are causing an anterior displacement of the mandible. So what is it? Whenever you are causing a head tilt chin lift maneuver, you are essentially causing, which is something which is called as anterior shift or anterior shift of your mandible. That is what you are causing. So when you are anteriorly shifting your mandible, or when you are displacing your mandible anteriorly, what is going to happen? Obviously, the tongue which is attached with the mandible is also going to move forward. So the tongue fall issue can also be taken care of. Similarly, when the epiglottis, you can also have an issue where your epiglottis is closing over the glottis. Your epiglottis will also be pulled away from the glottic opening. So basically, when you do a procedure which is called as head tilt chin lift, what essentially happens is that you are causing anterior displacement of the mandible, and along with the anterior displacement of the mandible, your tongue is also going to come forward, preventing tongue fall from happening, and also the epiglottis will also be pulled away from the glottis so that your airway becomes patent. So it is to maintain airway patency. It is a procedure that is done to maintain airway patency. But when you are attempting head tilt chin lift, you have to be cautious about one thing. Just look at this particular image here. This particular practitioner is providing head tilt chin lift. Now look at how the neck has extended, how much mobility your neck has to undergo if you want to do a procedure called as head tilt chin lift. Now this is a drawback of head tilt chin lift patient. Now imagine you are trying to resuscitate a patient and the patient is having a suspected cervical injury. Now in a patient with suspected cervical injury, what are you concerned about? You are concerned about further cervical injury, right? Now if you do this particular head tilt chin lift maneuver in a patient with suspected cervical injury, what can happen is it can accentuate the cervical injury and the patient might end up in permanent paraplegia, which you do not want. So if a patient is suspected of having a cervical injury, then you cannot perform this head tilt chin lift maneuver, right? Because there is significant neck motion happening when you are trying to initiate head tilt chin lift maneuver. So what will you do if the patient is having suspected cervical injury and still you want to maintain airway patency? You have another technique which is called as jaw thrust. Okay, you have another technique which is called as jaw thrust. So what do you mean by jaw thrust and how is this thrust? Let me show the image of jaw thrust here. So this is jaw thrust here. This particular person who is the provider is standing at the head end of the patient. He is standing at the head end of the patient. And then what he does is with his fingers, these fingers are holding behind the angle of mandible. If you can see, these fingers are holding behind the angle of mandible, and these fingers are providing a thrust which is directed anteriorly. A thrust is given to the jaw or to the mandible which is directed anteriorly. This is what is called as jaw thrust maneuver. Now, what is the significance of this particular maneuver? Similarly to your head tilt chin lift maneuver, here what you are causing is you are applying pressure behind the angle of mandible in an anterior fashion, and this is going to cause again anterior displacement of the mandible. It is going to cause anterior displacement of the mandible, and you know that if you are causing anterior displacement of the mandible, the rest of the story is going to be the same. Your tongue is also going to be pulled anteriorly. Your epiglottis will also move away from the glottis. So this simple procedure will also help you to open up your airway. What is the difference between head tilt and chin lift? Look at head tilt and chin lift maneuver here and look at the amount of neck extension which has happened here. Now look at this particular procedure called as jaw thrust. You can see that your neck is more or less remained in a neutral position. Your neck is remaining in a neutral position and there is no significant motion or mobility of your cervical area. So if you are suspecting a patient with cervical injury, then jaw thrust would be your go-to method to maintain airway patency. So suspected cervical injury, then your go-to method in maintaining airway would be your jaw thrust maneuver. In a normal patient, you can go for head tilt chin lift maneuver. Now, why do you think normal patient also can go under jaw thrust? Normal people can also undergo jaw thrust. But the significance that the point that you should remember is head tilt chin lift is slightly superior to jaw thrust in providing a patent airway. That is why in a normal patient, you can go for your head tilt chin lift maneuver. In a patient with suspected cervical injury, you will go for jaw thrust maneuver. Okay, so these are two procedures which are done for maintaining airway patency or opening up the airway. Now, head tilt, chin lift, and jaw thrust, they are together called as something which is called as triple maneuver. So you can be asked one question. All are components of triple maneuver except, and they'll give you options like head tilt, chin lift, jaw thrust, and something else. So you should remember that jaw thrust is a component of triple maneuver. And also please do remember that we will not be initiating all three in one patient. If a patient is not having any cervical injury, you would obviously go for head tilt, chin lift maneuver. If the patient is having a suspected injury or the patient is having an injury, then we will go for jaw thrust maneuver. So this is about head tilt, chin lift, and jaw thrust maneuver, right? Now, some more images I want to show you. What is this particular position? This particular position is otherwise called as sniffing position. It is otherwise called as sniffing position. And this is the position that we take up for a procedure which is called as endotracheal intubation. Now, if you want to put a tube inside a patient, if you want to put an endotracheal tube inside a patient, then this would be your go-to method, or this is the position that you want the patient to be in. What is this position called as? This position is called as sniffing position, right? This position is called as sniffing position. What is the technical term that you can use for sniffing position? It is called as cervical flexion. It is called as cervical flexion plus atlanto-occipital extension. Cervical flexion plus atlanto-occipital extension. So you are having flexion at the neck and extension at the atlanto-occipital joint. That is why it is called as sniffing position. Now, how do you achieve this sniffing position? You can see that this particular patient is having a headrest. There is something which is given for head support. Now, when the head is slightly elevated from the baseline, you can see that the neck joint here is now undergoing flexion. The neck joint here is undergoing flexion because of the support that you are giving here towards your head area. Secondly, the person who is going to intubate is obviously going to achieve head extension here. So this is cervical flexion here. This is extension here. This is what is called as atlanto-occipital extension, cervical flexion, otherwise called as sniffing position. Now, why do you want the patient to be in sniffing position? Imagine you are someone and you are trying to put an endotracheal tube into the patient's trachea. How do you go? You either have to go through your oral cavity or you have to go through the nasal cavity. Imagine you are going through the oral cavity. The tube has to first pass through the oral cavity, then it has to pass through the pharynx, and finally it has to enter into the larynx. Now, your oral cavity, it is like this. Your pharynx is something which is going like this, and your larynx is something which is going like this. Your oral axis, pharyngeal axis, laryngeal axis are all misplaced in a normal patient in a neutral position. Now, when you put the patient in sniffing position, what you do is you achieve a straight line orientation. Your oral axis, pharyngeal axis, and laryngeal axis all come together in one line so that you will be able to intubate the patient easier. Okay, so it is for oropharyngeo-laryngeal axis orientation that you put the patient in sniffing position. Okay, so this is one question which has been asked so many times in many types of exams all over our country. Cervical flexion, atlanto-occipital extension. The position for endotracheal intubation is sniffing position. They'll ask you cervical extension, cervical flexion, atlanto-occipital extension, flexion, etc., etc. So many combinations and permutations can come using this particular value. There is one more question which I expect to come in the next 2 years is how much degree of cervical flexion is required for endotracheal intubation. How much degree of cervical flexion? See here, there is cervical flexion here. How much degree of cervical flexion is required for a normal endotracheal intubation? And your answer would be 35 degree. Okay, this question has not been asked yet, but there's a high probability that if they want to ask a new question from your endotracheal intubation position, they can ask about how much amount of degree of cervical flexion is required for normal endotracheal intubation, and that would be 35 degrees, right? So this is your normal intubation position. It is called a sniffing position. This is what is taken for all patients. Just like what we mentioned for head tilt chin lift maneuver, when you are performing this position, you can see how much amount of neck mobility is required for this particular position to be attained. So again, if a patient is suspected of having a cervical injury, it would be catastrophic to try and putting this patient in this position. You cannot let the patient have such neck mobility if you are again suspecting neck trauma. So how do you intubate a patient who is having a suspected neck injury, right? That is what is called as this. This is what is called as manual inline stabilization. This is what is called as manual inline stabilization. So this is the method or position that is adopted for intubating a patient with cervical injury. We were initially mentioning about maintaining airway patency or opening up the airway, where we discussed the triple maneuver, head tilt, chin lift, and jaw thrust maneuver. Now we are talking about intubation positions. A normal intubation position would be sniffing position. But if a patient is having suspected cervical injury, then you go for something which is called as manual inline stabilization. It is very, very simple. I will make you understand what it is. So generally, if a person is trying to intubate someone, the person will be putting the patient in sniffing position. They will cause a head tilt and chin lift, and then with the help of your back support, there is going to be a sniffing position. So the person who is trying to intubate will still try to do the same. The patient will try to cause your flexion of the neck and extension of the atlanto-occipital joint while trying to intubate. Another person here, this particular person, if you can see, this particular person is actually holding the neck like this. This particular patient is holding the neck like this, and he is giving a counter pressure to what the other person is trying to do. This person is trying to cause cervical flexion and atlanto-occipital extension. This person is counteracting the forces so that the neck mobility will be reduced. So it is like stabilizing your neck. You are manually stabilizing the neck so that the neck will remain in line. That is why it is called as manual inline stabilization. So you can see that there are two functional persons here. One person is trying to intubate the patient. He is trying to put the patient in the normal sniffing position using his strength, while this person is holding the neck and limiting the motion of the neck or stabilizing the motion of neck. So manual inline stabilization is the technique of choice if you are suspecting cervical injury. So this is jaw thrust, which is done for opening up the airway in a patient with suspected cervical injury. And this is manual inline stabilization, which is the technique of intubation in a patient with suspected cervical injury. Right. So I had shown 4 images for you. So please do look at all these 4 images. This is head tilt chin lift. This is jaw thrust maneuver, this is manual inline stabilization, and this is the conventional sniffing position which is taken up for intubation. Cervical flexion, atlanto-occipital extension. How much degree of cervical flexion? 35 degree of cervical flexion. Okay. So this is about today's discussion. I hope you enjoyed the discussion. It is a very short, breezy discussion. It is an image-based question from your airway manager. Right. So we have discussed 5 different topics in the last 5 days. We'll come up with 5 new topics in the next week. So till then, enjoy your weekend. Thank you. Bye.
Recording stopped.